Bem, prezados amigos, bom dia. Nesses 20 anos de existência desse grupo de estudos, que se iniciou após uma reunião, quando tomávamos um café, depois de uma banca de um dos meus orientandos da pós-graduação, professor José Eduardo Monteiro da Cunha, professor Tarcísio Trivino e eu, éramos, à época, chefes dos grupos de via biliar e pâncreas das três principais escolas médicas de São Paulo: a USP, a Escola Paulista de Medicina e a Faculdade de Ciências Médicas da Santa Casa de São Paulo, isso, como vem aí, em 2002. E isso foi, de forma pioneira, uma reunião das três escolas em São Paulo, e que estabelecemos um grupo de colaboração, de estudos das desafiadoras doenças do pâncreas e seu tratamento, né? Tanto a sua parte de diagnóstico e tratamento. Nesses 20 anos de atividades, agregaram-se outros importantes colaboradores e agradecemos o apoio do Laboratório Fleury para realizarmos nossas reuniões presenciais em todos esses anos até o evento da pandemia no ano passado. Nesses 20 anos de existência, organizamos esse evento. Agradecemos a participação do professor Hackert, Thilo Hackert, de Heidelberg, Alemanha, e todos os colegas na organização dessa jornada, e em especial ao apoio logístico da empresa Etamicino e Wilson Cook. Quero perguntar ao professor Edson se ele quer falar algumas palavras, e depois irei fazer o agradecimento especial ao professor Thilo. Professor Edson, por favor.
Obrigado, Ademar. Bom dia. Realmente, eu estou emocionado, né, por esse encontro, reunindo todos nós em várias apresentações. É a primeira vez que isso é feito. A gente sempre fez apresentações de cada uma das escolas participantes e agora todas, praticamente, né, estão juntas, né, fazendo essa apresentação. E aí, com a participação de alguns convidados, né, de fora, para engrandecer essa reunião. Parabéns pela organização do evento e vamos em frente, né? Porque realmente é muita coisa para apresentar hoje. Obrigado.
Muito bem. Peço desculpas aos outros participantes do grupo, né? Porque não teríamos tempo suficiente, teríamos que ficar talvez mais de um evento, de um dia, para que todos pudessem estar participando. Enfim, vamos aqui dar início aos nossos trabalhos, né? E eu queria fazer um agradecimento especial ao professor Thilo. Lieber Herr Professor Hackert, erst, pardon für meine deutsche Sprache, aber möchte ich Ihnen danken, zu nett akzeptieren unsere Einladung. Herzlich willkommen. Professor.
Vielen Dank. Thank you very much for the invitation and this kind introduction. My pleasure.
Ok, professor Thilo. Danke. Danke Ihnen. Eu quero pedir para o professor Ardeg, então, assumir a coordenação das apresentações para que a gente dê início à nossa jornada.
Bem, bom dia a todos. É com um enorme prazer que a gente vai dar início a uma reunião de julho, né? Porque é uma coisa tradicional no nosso grupo é que a gente praticamente nunca fez reunião durante as férias e é a primeira vez que a gente está fazendo esse tipo de encontro, de evento. Eu queria também agradecer, em nome dos professores Ademar, em nome do professor José Eduardo Monteiro da Cunha e também do professor Tarcísio Trivino, a oportunidade que me deram para tentar organizar esse curso. Espero que todos vocês aproveitem da melhor forma possível, porque nós tentamos abordar os grandes temas, né, da pancreatologia, que realmente nos traz muita dúvida, muita discussão, e eu espero que vocês tenham uma manhã bem agradável em relação aos temas que nós escolhemos. Nós fizemos assim 5 mesas, onde vai ter um apresentador e vai ter um moderador, que normalmente é o responsável pela equipe, e 2 debatedores que foram especialmente convidados. Eu queria também agradecer a presença do professor Thilo Hackert, né? Dizer que realmente é uma grande honra tê-lo aqui conosco. Então, eu gostaria de dar início aos trabalhos, sempre lembrando a todos e eu gostaria que eu vou tentar controlar o tempo da melhor forma possível, com 20 minutos para a apresentação do caso e depois mais 30 minutos para a apresentação. Então, nós estamos começando agora. O Dr. Francisco Fará, ele ainda não está aqui, nós vamos fazer uma modificação. Vamos começar com a apresentação da pancreatite crônica, né? E eu gostaria de convidar o professor André de Morix para dar início às atividades.
Obrigado, Celso, pela introdução. So I think I'm going to start in English because we had in our module of chronic pancreatitis, we had our international guest, Thilo Hackert. Thank you, Thilo, for your presence here. It's a pleasure. Thilo is from Heidelberg, and we're gonna have a case presentation. That's Thalita Bernardo. It's our fellow in surgery, HPV surgery, that spent some wonderful time last year with Thilo in Heidelberg. So that's the reason she's gonna present this case. And then we're gonna follow with debates with the panelists, Dr. José Eduardo Monteiro da Cunha, full professor from Hospital das Clínicas, USP, and then Thilo. They are gonna be an open debate in this matter. Okay, so Thalita, the stage is yours. 20 minutes of case presentation, then we're going to follow with debates. That's it.
Okay, good morning all. I'm going to share my presentation with you. Please tell me if you can see it. Is everything okay?
Yes, we can see.
Yes.
Okay, so I'm going to start. Good morning, everyone. I am Thalita, as Professor de Morix presented me. I'm a fellow at HPV surgery at Santa Casa. I'm going to present this clinical case study about chronic pancreatitis. And first of all, I would like to thank the opportunity to be here with you in this special presentation and celebrating this study group. This is our surgical team, the ones who makes everything possible in our service. And so let's get started. The patient is GCA, 48 years old male, black, natural and from São Paulo and painter. He came to our outpatient clinic with the complaint of abdominal pain for the last 2 years. At his history, he was complaining about this pain for 2 years of strong intensity in epigastric and irradiating to right and left upper quadrant and back, associated with nausea and vomit, but with no feeding association. He complains of pain worsening in the last 6 months without improvement with the use of analgesics, and he had a weight loss of 5 kilos in the period, and denied any changes in bowel or urinary habits. In his past history, he reported an alcohol consumption of 400 grams of alcohol per day, which is equivalent of a liter of cachaça per day for 30 years, and stopped it 8 months ago. He also referred arterial hypertension in use of captopril, denied smoking or previous surgeries, and had no relevant information on his family history. On his physical examination, the only highlighted finding was pain during palpation of the upper abdomen, but with no palpable masses. His blood tests, the only alterations was his liver enzymes, which was high, and his glucose, which was also high, although he was never diagnosed with diabetes before. He was submitted then to a CT scan. This is the phase without contrast. And we also have the portal phase. Unfortunately, we don't have the arterial phase here, but I think that it's important to highlight in the CT scan two major finds: the dilated duct with the atrophy of parenchyma and the pseudotumoral mass at the head of the pancreas. And the interesting is that he had no calcification on pancreatic tissue or the ducts. This patient was then discussed in a multidisciplinary meeting, and he was referred to surgery and being submitted to a bigger procedure. I'm going to show you some pictures of the procedure now, and I'm going to discuss it during the presentation of the pictures. This is the first image. We do an extensive Cocker maneuver. Then we identify and isolate the superior mesenteric vein and do the portal tunnel. This specific step of the surgery sometimes can be very hard because of the length of the inflammation around the tissues. But in this particular case, we were able to do it without any major events. And then we proceed to the transection of the neck of the pancreas and the resection of the uncinate process and the head of the pancreas itself. Here it's the image of the procedure after the resection of the major tissue of the head of the pancreas. This is the final aspect after the excision of the head of the pancreas. This is the posterior, and this is the anterior image. Here, I'm going to highlight some things. First of all, we don't do the traditional beggar procedure. We do it with some modifications. The first one is that we always transected the choledochole duct, different of the original procedure, and we tend to leave only a thin layer of pancreatic tissue around the duodenum, just to preserve the gastropancreatic arcade. Then we proceed to the anastomosis. First, the pancreato-jejunal anastomosis, which we do differently too. We do a lateral, not a terminal one. Then we extend the opening of the choledochole duct longitudinally and do a choledochole-jejunal anastomosis, and then the other pancreatic jejunal anastomosis with the remaining pancreatic tissue. This is an illustration that Professor Demorix did to explain how is the final aspect of the procedure. In post-operative, this patient had no complications. He was discharged from hospital in good clinical conditions at the 10th post-operative day. I brought here some histological slides just to highlight some findings in chronic pancreatitis. This patient didn't have any pancreatic cancer cells findings in his histological exam, but he had intense fibrous tissue and an important atrophy and loss of the acinar cells, and also dilated ducts with the flattened epithelial cells that we find in chronic pancreatitis. I also brought some demographic data of our patients. At the last 26 years, we had 27 cases of bugger procedures at our service. 87% of them were male. The average age was 48 years old. Average sample weight, it was 44 grams, which is a little heavier than the usual data. And no patient had pancreatic cancer in the samples. We had 3 patients that had done previously Partington-Rochelle's procedure before the Becker procedure. So just to start our discussion and incite a little bit of the discussion, I also brought 2 articles to present you. The first one is the CROW-PAC trial. It was published in 2017. It was the first randomized trial, multi-center randomized trial that evaluated PD versus the PPHR. And it had some interesting results. The primary endpoint was evaluate quality of life after surgery of these patients, and there was no big difference between the groups. But I think that the very interesting results in this trial was with the secondary endpoints, and I think Professor Thilo can discuss this after, since he was one of the main heads of this trial. But which was interesting, it was the frequency of readmissions after surgery and the necessity of another surgery, and the functioning of the pancreas and the impact of this in the life of the patient after surgery. They favored the realization of the pancreatic duodenectomy, and it was a little bit different of the previous studies showed. And the other study is a systematic review and a meta-analysis of Professor Becker that was published last year about the effects of the resection of duodenum in patients with benign tumors. And the meta-analysis favored not the resection of the duodenum, because of the high incidence of new onset diabetes and pancreas exocrine insufficiency after doing WIPO for patients with chronic pancreatitis. So I think these are some topics that will be interesting for us to discuss now. And I would like to thank you all for this opportunity.
So thank you very much, Thalita, for your nice presentation. Very nice, very clever one. So I would like to start with the panelists, with Dr. José and Dr. Thilo. The first question that appears to me here, I saw the case and we prepared, is how important is to define or do a previous biopsy in this head pancreatic masses, because we had 3 to 7% of pancreatic cancer in this kind of patients with chronic pancreatitis signs. So I would like to discuss the importance and how long should we go and how far should we go in this biopsies attempts, or it's not important. We've got a very severe history of alkaline intake and classical chronic pancreatitis cases. So I'd like to start with Dr. José Eduardo, how it's important to define the diagnostic with biopsy or not, by US, by endoscopy. What do you think, Dr. José Eduardo? Please.
Thank you, André. And I want to congratulate the presentation of this case. It was a very nice presentation, a very nice case. And regarding to your question, we are not very much concerned about the concomitance of pancreatic cancer and chronic pancreatitis. At the hospital clínicos in São Paulo, of the University of São Paulo, we had more than 700 cases of chronic pancreatitis along about 20 or something years, and we did not have one single case of pancreatic cancer. So in our experience, pancreatic cancer is not frequently associated with chronic pancreatitis. And we don't think the biopsy is a very good thing for diagnosing pancreatic cancer, mainly in this case of suspected chronic pancreatitis, because as you know, in all cases of pancreatic cancer, there is always a tissue of chronic pancreatitis around the tumor. And for this, the incidence of false negatives, if the biopsy is taken only the chronic tissue, inflamed chronic tissue around the tumor, then you would misdiagnose the cancer. So we don't do any biopsies in our cases. They are all very characteristic case of chronic pancreatitis, most of them with calcifications, with I did not see in the case that was presented today. But anyway, we are very sure and very confident that the patient has chronic pancreatitis and can be submitted to one of the procedures that we do in our service. We can discuss this later on.
Okay. So Thilo, what do you usually do in Heidelberg to make the diagnosis or the attempt to see if there's a cancer or not? I remember in the ProPath randomized trial that is 3 to 7% of cancer in those cases, 250 cases almost. And so what we usually do and the importance of the biomarkers, CA99 and biopsy by US, what do you usually do in your service? Thilo.
I would agree with what has been said before. We do not do a biopsy routinely because exactly of the same reasons of the false negative results. And we all know that there is chronic pancreatitis around the cancer. And therefore, usually you have some clinical things that you decide about this. I mean, the chronic pancreatitis patients are younger. Usually they have a characteristic history of their disease. And the pancreatic cancer patients usually are the ones that are older and they have no history. So from this point of view, I think mostly this is quite clear. CA99, of course, can help you if you have no cholestasis. Therefore, I think it's not necessary to have this biopsy. And of course, we all know that we have these something like 7 to 10% of patients that undergo a Whipple with a suspicion of malignancy. And finally, it's chronic pancreatitis, which is not a problem at all, I think. On the other hand, you have sometimes, and I remember 3 patients where we had chronic pancreatitis suspicion, and then it was cancer that we operated on. And 2 of them was the intraoperative frozen section. Then we just converted to the Whipple. And 1 was only the final histology that revealed the pancreatic cancer. And we wanted to reoperate this patient, but he refused for the second operation. So of course you have these cases very rarely, but they do exist. I've seen 3 of them. So it's not 100%, but it's nearly 100%, I think.
Okay, nice. So I'm going to continue with you, Thilo. And in this specific case, we didn't see calcifications on the head of pancreas. So it seems to be some kind of groove pancreatitis. When you get groove pancreatitis and without calcification, and if you had jaundice or portal hypertension, this it's important to decide what kind of procedure you're gonna do, duodenum-preserving procedures or pancreatic duodenectomy. It's gonna differ, or it's gonna influence your decision in what surgery you're gonna perform, or it's not important.
Of course, it does influence the decision. If you have not the typical findings of calcifications, it's more difficult. And in the case that Talita presented, personally, I think I would have done a Whipple procedure because of the missing calcifications, although the history, of course, was quite clear with the alcohol abuse and all these things. But still, I think you could have also done a Whipple. And what I really liked was your modification of the Vega procedure, because you really take away a lot of the pancreatic head. I mean, there is no dorsal parenchyma anymore. You take it away near total in the head. And this means you always also transect the bile duct, which not everybody does in the Vega procedure, of course. And I think this is one of the problems why in the PROPAC study, there were these reoperations, because people take away too little of the tissue, not enough. And this is what I like about your operation that you had shown, that you really take it away very extensively, and then you don't face these problems of a second operation because of a cholestasis again or something. But I think a Whipple would also be possible in that patient, especially as you said, the portal vein was not the problem. There was no big bleeding. You could really transect it and you could tunnel the pancreas. Then this would have been an alternative from my point of view very well.
So this modification that we showed to you and you pointed out was introduced by Dr. Ademar. He learned in the 90s with Hans Gutenberg in Germany to do this procedure. So he brought to us this knowledge and did this modification, and we made our cases, all of this. And it's avoid next procedures. That is pointing out in PROPATH. There's a number of procedures and need to a second procedure because chronic pancreatitis appears again. So that's a good point. And Dr. Eduardo, and what about a Fry procedure? I know that in your institution you got you do pancreatic duodenectomy as well as you do Fry procedures in chronic pancreatitis with head sealed tumors. So when you to decide one and another procedure, what is the important point?
We are very happy with the Fry procedure. As a matter of fact, we had about 25 or something cases done, and the criticism of the Fry procedure, mostly from the German and the European centers, is that that you do not resect enough pancreatic tissue with the Fry procedure. We, in some cases, we measured the amount of tissue that was resected, and they weighed an average of 50 grams, some as much as almost 60 or 7 grams of pancreatic tissue. And we decided to do the Fry because actually it's more, the present case that was presented today was very fortunate that the fibrosis around the portal vein was not very intense. So it could be done quite easily. But usually the fibrosis there is quite important. And the Fry procedure avoids you going down that way. And so we had very good results with the Fry procedure. About in a 5-year follow-up, 80% of pancreatic pain relief and almost no pancreatic function insufficiency, which is the major problem with the pancreatic duodenectomy. If you compare the Fry procedure with the duodenopancreatectomy, there are many reports, as you know, comparing that, starting as early as in 212, and Dr. Zhang, in a publication, showed that the Fry procedure was superior to the duodenal as far as bleeding and pancreatic fistula and some other issues that were better with the Fry than with the duodenal pancreatectomy. We had some cases that we did a pancreatic duodenectomy, and in cases as the case presented today with the pancreatic head mass associated with the pancreatic duct dilatation, Dr. Marcel Machado and I published a procedure combining the two cases, the resection of the pancreatic head through a Whipple procedure, and then opening the pancreatic duct dilated by pancreatic duct and doing a procedure similar to the Partington Rochelle, of course excluding the pancreatic heads that had been resected already. And this was a very nice experience and very good results with pain relief and no complications in the case. There wasn't many cases done with the procedure, about 10 cases only, but that was a good thing to do. The major concern, our concern with the pancreatic head resection through a Whipple procedure is the worsening of the pancreatic function that is always been associated with the Whipple procedure. Both endocrine and exocrine function are very hampered with this procedure. So, but in the cases I present today, I agree with Dr. Thilo that the absence of pancreatic calcifications is kind of worrisome as regarding as possible existence of a pancreatic cancer. As I said before, we were fortunate enough not to have not one only case of pancreatic cancer in over 700 cases followed for pancreatic chronic pancreatitis. Thank you, Andre.
So thank you. What a point you said, Dr. Eduardo, is the importance of preserving or not the duodenal regarding to nutritional effects of the surgery. So this is what I still defend here and the last published paper that Thalita showed to us. So I'd like to ask just Thilo, what long-term nutritional effects when you decided to perform a Whipple and to preserve the duodenum? It does really matter in the disease long-term surgery or not, because better seems to be done. It's a very challenging procedure for a lot of surgeons. So it's not easy to preserve the duodenum and resecting completely the head, preserving the pancreatic duodenal arterial arcade is very challenging ones. So there's modifications, blend modifications, Fry modifications, trying to avoid the vascular aspects of the SMA and SMV. So what do you think, Thilo and Eduardo, about this aspect? We should do pancreatic duodenectomy and don't worry about this nutritional effects as exocrine dysfunction after a long-term exocrine dysfunction on this disease, or we should preserve the duodenum in this disease? Thilo.
Well, this meta-analysis that was shown from Hans Beger, of course, suggested that it is better to preserve the duodenum. From my knowledge, in the big trials, this has not really been an issue in the past, because you can substitute the crayon, you can substitute what you need. And in the CROPAC trial, for example, the quality of life in all dimensions, which means also the nutritional dimension, the social functioning, the emotional functioning, the professional rehabilitation, all these things, the weight of gain weight was the same between duodenum preserving and the Whipple procedure. It was no difference. The only difference was the re-interventions or reoperations and readmissions, as Talita pointed out. And therefore, in this randomized trial, there was no big difference. I don't see that good to preserve the duodenum if you therefore compromise the effect of your operation. As we said before, the effect of risking recurrence of the chronic pancreatitis, risking another cholestasis episode, risking another operation with bile duct anastomosis or things like that. If you feel comfortable about everything, the duodenum is preserved and you are happy with what you have resected, preserve it. But I would not preserve it for any price, just because of the fear of nutritional changes or exocrine insufficiency or things like that. I think that is not really very well evidence-based, to my knowledge.
Okay, thank you, Thilo. Dr. Eduardo, another point on this matter?
Yes, when the Bagger and the Fry procedure were described, there was really a very expectation about the better quality of life and pain and weight gain and everything, but this was not proven. And many studies, most of them done by the German school, Dr. Isbisky did many comparative studies. And the end result seems to be what Dr. Thilo just mentioned, that there was no big difference as far as quality of life or weight preservation and everything, if you preserve or not the duodenum. We're more concerned about the extent of the pancreatic resection than the duodenum itself. Whenever possible, we try to preserve the duodenum and the pancreatic head with the Fry procedure. But I'm not quite sure about the importance of the duodenum preservation nowadays.
Okay. There is a question from Susan, who's a radiologist from IBM. What kind of information are you looking for in the exception of cancer? Susan, wanna point this? What are you pointing? It's image information that you're looking for, calcifications, nodules. What you're pointing? Susan, you want to ask?
Yes.
Yeah.
Hi. Hello.
Hello.
The thing is that the case that you presented, it's more likely for radiologists to say that this is probably a cancer or a cancer with chronic pancreatitis, because it is so difficult to differentiate a mass in the head of the pancreas between these two entities, especially when you have atrophy of the pancreas, a mass in the head, and no calcifications. Of course, just a CT, a computed tomography, it is too difficult to do this differentiation. But as all of you shown, there is no need to say if there is cancer inside of this mass, because the clinical presentation of this patient, with a clinical presentation, you decided to go on surgery. My question is, what kind of information can a radiology say that it will change or it will help your surgery or decisions?
I think it's a hypovascularized nodule or a mass in the head of pancreas. I don't know if MRI can help us in this kind of situation. I don't know if Thilo has an opinion or not that could direct some direct some US biopsy, guide biopsy. I don't know, perhaps hypovascularized mass or nodule in the head can change your strategy in those cases. I don't know. What do you think, Thilo?
Of course, this can change your strategy. If you have this typical hypovascular finding, which is very highly tumor suspicious, I would take it as a tumor right from the beginning. But of course, this is sometimes one of the most difficult things to differentiate. Also in the MRI, it's not that helpful. I can just present you two little cases, if you don't mind, where
Yes.
this is a really pitfall. I'll just try to share this. I think we could do this like...
Thilo, be my guest.
Yeah, okay. And then we go to the full screen mode. And maybe... Can you see this?
Yes. Yes.
Okay, so this is, for example, something which is, I think, extremely difficult to say, is this chronic pancreatitis or cancer? Is this chronic pancreatitis or cancer? I mean, we could ask the radiologist, what do you think this is?
It's impossible to say in just this image. This is a hypovascular image. It is impossible not to say this is not a cancer, but the other image, again, it is very, very difficult to say because it's a hypovascular imaging. It's
I'm sorry, I just have...
Dr. Thilo, thank you for your images. I would like to know, in a case like that, for example, in a case like that, what do you think about the EUS FNA or now, at this moment, the EUS FNB?
In this specific case, if we look at the left side, and you really have the suspicion of cancer, this would be a locally advanced cancer. I think in this patient, we would go for a biopsy because we would do a neoadjuvant treatment. Of course, the bad thing is, what would you find? You would find chronic pancreatitis, and you would not be sure what to do then. Extremely difficult, I think. You would probably do another biopsy. Maybe this was conclusive, fine, maybe not. And in this case, of course, this might be resectable in some way, maybe with a portal vein, whatever, no problem. But then we would go for surgery. And I think another thing that I can just show you, and also with some radiological pictures, this is one father of a colleague of mine, actually also a radiologist, 66 years of age, male patient, back pain, a little amylase lipase elevated, and his brother died of pancreatic cancer at the age of 70. He came to us with his finding. You see this problem here in the pancreatic body. And also in the T2, you see this dilated duct downstream. And of course, you don't really see a tumor, but you have this typical history and you have a family history. What did we do? Of course, we did a distal pancreatectomy for the suspicion of pancreatic cancer. And finally, it was a focal chronic pancreatitis. I think impossible to find out before. And to do it vice versa, this is nearly the same case. Female patient, 58 years, suspicion of autoimmune pancreatitis. This was the finding. We saw something like that in the MRI and something like this. You see, this is not a big thing, but a little dilation of the pancreatic duct here. And we did, once again, an operation because we were not really sure, but autoimmune pancreatitis was the favored diagnosis, and did a distal pancreatectomy again, and it was a T3 tumor in this patient. Of course, there was no difference regarding the surgical strategy. We did the same operation that we would have done for autoimmune pancreatitis or for chronic pancreatitis if no other therapy would have been there. But you can see these are the pitfalls, I think, and these patients every one of us has seen in the past or will see in the future.
I see. Interesting. So I think we're getting close to the end of this module. I'd like to open for questions from audience or for other surgeons. If you want want some questions, it's open. Dr. Ademar, I can see Dr. Rezende, Alexandre Rezende is is here. So it's nice to see you here, Dr. Alexandre, with us. So if you can do some questions.
I would like to do a comment, please. First of all, good to see you, Thilo. Good to see, especially in this moment where there's kind of problem in German. I hope it's everything all right with you and your family. I would like to expose that I think I am a bad luck surgeon because I have a very less experience in chronic pancreatitis, and I have 2 cases of pancreatic cancer, not by misdiagnosis, but by association of the 2 diseases. I had 2 patients with typical chronic pancreatitis, long-term evolution, duct dilation, calculus in the duct, and operated them on, I did a free procedure in both cases, and in both cases, on post-op, I received the diagnosis of pancreatic cancer. And this one patient I reoperated on and performed the Whipple procedure. The second one was two months ago, and the patient is under chemotherapy, neoadjuvant chemotherapy, and I will do the surgery later on. I would like to point out that there are 2 patients, they are young patients, less than 50, and with no association with alcohol abuse. So they are chronic pancreatitis, idiopathic or familial cause of pancreatitis. I would like to advise that perhaps in this special group of non-alcoholic pancreatitis, we should take more care about the association of cancer. I don't know what Thilo's experience and José Eduardo, if they wanted to point out something about it.
Nice questions, Thilo, please, and Eduardo, you can answer these questions. Good point. And remember, IPMN as a disease that can develop a chronic pancreatitis as well, and sometimes it's challenging in some cases. So, Thilo and Eduardo, please.
Alexander, yes, thank you very much. I agree with you that this is very difficult. And if you don't have the typical history of the patient, then I think I would always think of cancer, favor the diagnosis of cancer, even if it's a young patient. He has no history of drinking, smoking, all these things. I think this is the only thing that you can rely on. Maybe CA19-9 if it's elevated, yes, but history is more important.
But this patient, Thilo, they had long history of chronic pancreatitis. They've been on follow-up for a long period with typical chronic pancreatitis, and then developed pain and went to surgery. And on surgery, we developed not by misdiagnosis, but by association of both diseases.
Because that's the worst situation you can have. You will have all signs of chronic pancreatitis, and then it turns out to be the different disease. So this is something, you cannot prohibit.
Bad luck.
Bad luck.
Yes.
José Eduardo?
Yes, well, I think it's a very difficult case, but of course there are different diseases. If you have the alcoholic calcific chronic pancreatitis, then, which was the majority of our cases, then the association of pancreatic cancer, at least in our experience, was, as I said, extremely low. But in the case that Alexander showed, referred to, there is different case. With the hereditary chronic pancreatitis is well known, associated with pancreatic cancer in a high percentage of cases. And even though the patient had a history, and if I can remember, they did not have alcoholic intake, right? So non-alcoholic chronic pancreatitis, even in young patients, and we must be aware of the concomitants of pancreatic cancer, yes. But very difficult, yes, I agree. Very difficult.
Oi. André?
Celso?
André?
I think we lost. Andre contact.
Seem they lost their sign.
Yeah,
they're not online at the moment.
I can see his image. I can't hear his voice. Ademar and Andre are gone.
Well, let me. What would you have done on this case, Thilo? Would you do a surgery for chronic pancreatitis? You find out that on later exam that it was a cancer. Would you do an upfront second surgery, or would you do a neoadjuvant chemotherapy?
Well, if it was resectable and the patient would agree, I would do a second surgery right now, if that is technically possible. If you have the problem, for example, with a portal vein that you have experienced and still it's cancer, I would maybe go for some 3 months of chemotherapy, as you have decided in the second patient that you just mentioned, and then do another operation. But if you know it in the final histology and not in the frozen section, this is kind of difficult. I mentioned these 2 patients where we had this problem. One we reoperated and the other one refused for the reoperation on his own decision. So you could not help him, of course. But I think if possible, second operation, oncological, and then adjuvant therapy.
Dr. Thilo, can I ask you a question? There is a difference between the presentation, the morphological presentation of chronic pancreatitis in Germany and in the United States, for instance. Could you explain us, because there is a preference in the United States for the Frey procedure and in Germany for the Beggar or similar procedures. Could you give some information about that, please?
Yes, that's a strange observation that in the German or the Western European patients, you mostly have this head mass, and then the tail is not the problem. Therefore, you go to the head, you solve the problem in the head, and that's fine. In the US, somehow this head mass is not that prominent in many patients, but it's rather that the body and the tail are also enlarged. And then, of course, you need to go further to the left to really decompress the duct sufficiently. And I think that was the reason why Frey modified this operation, going further to the left. And I think no one can explain why the European patients have this morphology and the US patients have the different one. What is it like in Brazil? What do you see more often? Which one of the 2 types?
It's more like the United States. I think it could be for the amount of beverage, no?
Well, possible.
In Germany, you drink more, no?
We drink more beer, yes. You drink other things.
Thank you.
Probably the difference between cachaça pancreatitis and beer pancreatitis, I don't know.
Yeah.
We should describe this, yes?
Yeah, but here in Brazil, at least in our experience, we have really both things. Like in the United States, the head of the pancreas enlarged and the pancreatic duct dilated. So that's why the Frey procedure seemed to us to be quite nice operation. Dealing with the...
Sorry, I lost my contact and my web, so this moment. Sorry.
Okay.
Well, we finished. Sorry, I my contact momentarily, so I don't know what point we are. So we pass through the next presentation or not? We finished?
Well, I'm quite happy. I congratulate you all of you. Thank you for this opportunity of being here again with you, Andre, Thilo, and everybody.
Okay. Thank you, Dr. Zadar. It was my pleasure, and it's always a pleasure to share with you this table. Always a pleasure.
Thanks a lot.
Thanks a lot. Ok, Celso. Vai ser o Kiko ou vai ser o Edson? Quem vai apresentar agora?
Eu não estou vendo. Estão me ouvindo?
Caiu da sala, doutor. Ele ainda não retornou.
Estão me ouvindo?
Estamos te ouvindo, doutor Ademar.
Eu estou sem a câmera aqui agora, não sei o que houve. Mas
O
eu acho
doutor
que
Celso retornou, ele tinha caído.
André, tinha caído aqui, acabou a energia aqui. Bom,
acabou aqui também. Acabou aqui também, mas aí depois voltou.
Vamos dar continuidade, então. Eu gostaria de convidar, então, o próximo apresentador. Eu acho que o Kiko vai ficar por último mesmo, porque ele não me respondeu até o momento. Então, eu vou anunciar o apresentador, que é o pessoal da Unifesp, que vai apresentar o câncer de pâncreas, né? Então, eu pediria para a Bárbara Nadaleto, né, da Unifesp, que é apresentadora, poder compartilhar sua tela com a gente. Quero mais uma vez agradecer a todos os participantes desse evento. Quero parabenizar também a participação do Dr. Thilo na última sessão, que eu acho que foi extremamente importante, e de todos os panelistas que estão aqui presentes. Então, nós temos mais 50 minutos. Obrigado, André, por ter feito o seu módulo no horário. Muito obrigado mesmo. Um abraço. Vamos lá.
Celso, before Barbara begins, I would like to know if Dr. Eduardo is present here, because it is important to have him in this presentation.
Ok.
Dr. Eduardo Fernandes, are you here?
Doutor Eduardo Fernandes está presente? Eu acho que você pode começar, Edson, e se ele for entrando, né?
Acho que ele não tá, eu
acho que ele...
Oi,
bom dia. Eu falei,
dia.
estava falando aqui com o Dr. Franz acabou de falar com o Eduardo, ele estava em um transplante, ele vai se conectar daqui 5 minutinhos.
5 minutos.
Então, vamos começar. Isso.
Acho que como ele conhece o caso, já a gente pode ir começando, né?
Sim.
Everyone...
Pode começar, Bárbara, fica à vontade.
Okay, good morning, everyone. Can everyone see my screen?
Yes.
Yeah.
Yes.
So thank you for the opportunity of being here, presenting to you. My name is Barbara Nadaleto. I'm a 4th-year digestive surgery resident at Federal University of São Paulo. I made this presentation alongside with Parisina, which was the former presenter. In our case, our moderator is Dr. Edson Lobo, and our debaters are Dr. Eduardo and Dr. Pedro. We would also like to thank Dr. Marcelo Linhares, Dr. Daniel Shirayo, Dr. Alberto Goldenberg, and Dr. Franz Apodaca to the contribution to this case. Our patient is a 40-year-old man, obese, with body mass index of 32. He had previous records of hypertension and type 2 diabetes and dyslipidemia, and he had a previous laparoscopic cholecystectomy elective. He had no allergies, no alcohol or tobacco use, and he was admitted to the hospital with a complaint of the abdominal pain with a long onset, but was worsened in the last week before admission. He had no consumptive or cholestatic symptoms, and on the physical examination, he had a painful palpation of the upper abdomen. So to the investigation, we performed an upper abdomen MRI, which showed an enlargement of the pancreatic body and tail with an heterogeneous contrast enhancement of the pancreas and peripancreatic fat. It also showed an splenic vein thrombosis and an irregular splenic artery. This mass had close contact to the celiac trunk and celiac node, and it showed no vasodilatation or parenchyma atrophy. The final conclusion suggests a primary neoplasm. Here in the MRI, we can see the enlargement of the pancreatic body and tail with an heterogeneous contrast enhancement. The pancreatic head was preserved, and here the close contact to the splenic artery and the celiac trunk. In this other image, we can see also the close contact to the celiac trunk and celiac node. So we chose to perform an endoscopic ultrasound biopsy, which showed the same hypoechoic heterogeneous lesion on the pancreatic body and tail with irregular borders. And the pathological finding of the biopsy was an invasive adenocarcinoma. So due to this finding, in February 2020, we chose to perform an open distal pancreatectomy with splenectomy. And the pathological analysis confirmed an invasive ductal adenocarcinoma with the size of 3.9 centimeters. The surgical margins were clear. There were 2 positive lymph nodes due to the proximity of them to the tumor. The histological grade was moderately differentiated. It had a perineural invasion present, multifocal, but had no lymphovascular invasion. The final classification was PT2 PN1 M0. So the patient recovered well from the surgery and was submitted to adjuvant chemotherapy with FOLFOXIRI, 8 cycles from April 2020 to July 2020. But due to a raise of the tumor marker during the follow-up, we also performed radiotherapy sessions and changed the chemotherapy scheme to capecitabine. Here is the CA-99 timeline. The CA-99 on the admission was 91. Then it had a fall due to the distal pancreatectomy, and then it rises again. So we changed the chemotherapy scheme and performed radiotherapy, which made a downgrade, but then in the follow-up, it started raising again. In the imaging follow-up was performed by abdomen MRI, and the June 2020 upper abdomen MRI had no signs of recurrence, but showed an hepatic hilum lymph node with 2.2 centimeters, which was stable compared to the 2020 March 2020 MRI. Then in October, it shows a fat strain in the surgical site and the celiac trunk, but no suspect of recurrence of the neoplasia. The hepatic hilum lymph node was steady compared to the previous examination. But in January 2021, the upper abdomen MRI showed a suspected hypovascular lesion in the surgical site and celiac trunk and node, and also showed a narrowing of the hepatic and left gastric arteries, as we can see here in these images. Here we can see the mass. Here we can see the mass in the pancreatic head close to the celiac trunk. Here we can see the narrowing of the hepatic artery. And here we can also see the close contact to the hepatic artery and in the sagittal and the coronal images. So in March 2021, he was submitted to a PET-FDG PET scan to confirm the diagnosis of recurrence. And it showed a lesion in the celiac trunk and a superior mesenteric artery with augmented glycolytic metabolism, and it shows an enlargement compared to the January MRI. And it confirmed the diagnosis of suspected recurrent neoplasia. Here in the PET scan, we can see this mass in the pancreatic head involving the celiac trunk and close contact to the superior mesenteric artery. Here in the sagittal and coronal images, we can also see this augmented glycolytic metabolism. So in April 2021, it was chosen to perform a gastropancreatic duodenectomy through a mesenterical approach with a total mesopancreas excision. It needed to do a celiac trunk and portal vein resection with vascular reconstruction. We made a bridge from a superior mesenteric artery to with pancreatic duodenal artery to the left gastric artery. We also need to connect the celiac artery stump with the hepatic artery with an interposition of cadaveric donor graft, and also had to fix the portal vein resection with an interposition of cadaveric donor graft. The hepatic hilum lymph node suspected that was shown in the previous MRI were submitted to frozen section biopsy, and they were negative. The reconstruction was performed by a single loop with a brown enteroenterostomy. The operative time was 14 hours, the blood loss was 700 milliliters, and the patient received 2 red blood cells packs during the surgery. And he ended up the surgery with high doses of vasoactive drugs. Here we can see the surgical specimen. Here is the end of the distal part of stomach. Here we can see the first part of duodenum and pancreatic head, and the rest of the duodenum and the peripancreatic effect, the mesopancreas. And we also had to perform to resect the first part of the jejunum due to the mesenterical approach. Here you can see with more details the first part and the second part of the surgical specimen. Here is the vascular reconstruction. Here we can see the superior mesenteric artery. Here is the pancreatico-duodenal bridge to the left gastric artery. And here is the interposition graft connecting the trunk stump to the hepatic artery. And here underneath we can see the portal vein with the vascular interposition graft from cadaveric donor, and here inferior vena cava. I'll show now a video of surgery. I don't see the video, but here we can see the portal vein. Here we can see the inferior vena cava. Sorry, the portal vein. Here the inferior vena cava. Here superior mesenteric artery. The bridge with a pancreatico-duodenal artery to the left gastric artery, and here the bridge with cadaveric donor graft from superior vena cava, superior mesenteric artery to the hepatic artery. So I'll resume here. Here is the brown enteroenterostomy, and here is the closing of the gap of mesenterial. In the immediate postoperative, the patient was transferred to intensive care unit with under invasive mechanical ventilation with a systemic inflammatory response, needing high doses of vasoactive drugs and with renal and hepatic dysfunction. In the first postoperative week, the patient overcame SIRS and overcame the organic dysfunction that he presented. In the second postoperative week, he evoluted with abdominal distension. So we performed a CT scan that shows less enhancement of the gastric wall and an upper digestive endoscopy, which shows an ischemia of the gastric mucosa. We chose to do the conservative therapy with fasting in a nasogastric tube to decompress the gastric chamber, and hyperbaric oxygen therapy. The patient had a good response to the conservative treatment. So in the third postoperative week, the gastric ischemia was solved. As we can see here, we can see a better enhancement of the gastric wall, and the upper digestive endoscopy was normal. The patient resumed the enteral diet, evolved with diarrhea as expected due to the surgery, which was treated with loperamide and pancreatine with good response. He also had a good glycemic control with insulin, and in the postoperative day 25, the patient was discharged from the hospital with oral diets. So the pancreatic, the pathological findings were a pancreatic ductal adenocarcinoma with a size of 3.7 centimeters with an extension to the peripancreatic fat. The surgical margins were clear. It had a really celiac artery and portal vein invasion, and the histological grade was moderately to poorly differentiated. The lymphovascular and perineural invasion were present with tumor budding, and 2 lymph nodes from 28 lymph nodes dissected were positive. The gastric, hepatic, and retroperitoneal lymph nodes that were dissected were clear. And the final classification was RPT4, RPN1. The immunohistochemistry showed the pancreatobiliary immunophenotype with preserved DNA mismatch repair enzymes. The patient had a good surgical recovery and now is currently through oncological follow-up with adjuvant chemotherapy with gemcitabine and nab-paclitaxel. So we brought this case to discussion for some reasons. One of them is for the surgical technique that was chosen with a posterior mesenterial approach, which is not the most common approach to a duodenal pancreatectomy, and also because of the second pancreatectomy for a recurrence of pancreatic adenocarcinoma, which is a controversial indication for the surgery, but in selected patients can improve the disease-free survival and the overall survival. So the patient was young, he had a good performance status, so we chose to try to complete the total pancreatectomy to improve these outcomes. Thank you.
Dr. Edson, please.
Okay.
We are waiting for your comments.
First of all, thank you, Barbara, for the good presentation. Perfect, almost perfect. And we could see a very interesting case of pancreatic cancer, a very uncommon, let's say, treatment for this awful disease. And there are so many aspects that we should discuss in this case, because the experience all over the world is very low. I would like to know if Dr. Pedro Moraes is one of the debatant of the discuss, if he is present, because I would like to begin with him. Pedro, are you there? Pedro is the clinical oncologist that works in Unifesp, at Federal University of São Paulo, and in the private hospital Albert Einstein. He is one of the oncologists at this hospital. And Pedro, you know this patient from the beginning, right? And we like to ask you some doubts, because our experience with this kind of treatment, arterial resections, for instance, is low. To be true, it's the first case with arterial resections. We don't have any experience, and we thank you for your participation in this case. Well, first of all, from the first images of this patient before any treatment, we could see some signs of possible local compromission of the arterial components of the. Shouldn't you begin with a new adjuvant therapy for this patient?
Yes. First of all, I would like to thank everybody from the organization, and especially thanks for the invite. And I'd like to say I'm sorry for being inside my car, but I was catch in the middle of the trip. And this case has a very uncommon presentation. I'd like just to chant a little detail about the history. The radiotherapy with capecitabine was a pre-planned strategy. It was not just done because of the CA19-9 elevation. I was planning that because we have some kind of doubt about the posterior margin on the first resection. And then this patient was closely followed by images. I thought about doing some kind of new adjuvant therapy from the second treatment. I just choose not to do it because I thought about following this patient. So the first time the CA19-9 arrives, I have an image showing just local recurrence. First thing I thought about doing was not treat. I followed this patient for 6 weeks more, and in the 6 weeks follow-up, it has no sign of metastatic disease. So after 6 weeks of follow-up and confirming I have only local recurrence, I chose to give this patient local therapy because this disease had a presentation with local problem and not systemic problem, even with the follow-up and 6 weeks after the recurrence was diagnosed. We tried to have local therapy and we discussed this case with our people from interventional radiology to see if we could have some kind of local procedure, just like microwave or radiotherapy again, but it was not possible because of the location of the local recurrence. I couldn't offer this patient any other kind of local therapy, only the surgery, and we chose to have the surgery because we have no evidence of metastatic disease. Even after the surgery, the CA19-9 was a little higher than I would like. I tried to have this patient, I don't know if everybody's familiar with ctDNA to find minimal residual disease, but this patient unfortunately couldn't afford this test. In the absence of the test and in the presence of CA19-9 that doesn't fall the way I would like, I chose to start a second round of chemotherapy with Janzar and nab-paclitaxel.
Okay, the first scheme that you chose was FOLFOXIRI and not FOLFIRINOX. That is the more common neoadjuvant or adjuvant therapy for pancreatic cancers. I know that they are the same drugs that you use in both treatments. And why did you choose this FOLFOXIRI and not FOLFIRINOX?
In fact,
yeah.
Edson, but in fact, the patient received modified FOLFIRINOX, not the FOLFOXIRI regimen. Okay, I don't use the classical FOLFIRINOX because we know from Prodigy trial and from another trials that tried to use the full dose FOLFIRINOX, we have too much toxicity, including difficulty the surgical procedure if we use this in the neoadjuvant setting. So nowadays, I only use modified FOLFIRINOX that has lesser dose from irinotecan and fluorouracil. So this patient received 8 cycles of FOLFIRINOX. I chose not to go over 8 cycles because this patient is a photographer and singer, and he was started to sing some neuropathy from oxaliplatin, and I was afraid that my problem would be local recurrence, so I chose to go over radiotherapy and capecitabine, trying to get the best local therapy I could offer to this patient. Unfortunately, even with the best local therapy we have as BRT, not the radiotherapy regular scam, with a very high local dose, 50.4 grays, if I'm not mistaken. Even with this kind of therapy, this patient had only local recurrence, showing that this patient has a different kind of adenocarcinoma of pancreas and not so metastatic the way we usually see. Only 30% of the patients have recurrence only local recurrence and non-metastatic disease. So this patient has a kind of special tumor. Our pathologist, unfortunately, he can't be here, Vanderlei. We discussed a lot about this case because this tumor has a very high perineural invasion, much higher than the usually adenocarcinoma of pancreas. And even with this important perineural invasion, we have only local recurrence. I'm awaiting the NHS from the tumor. I still do not have this result, but I think this tumor has some different, maybe not KRAS mutation. I don't know yet. I will know it in the next 15 days. Unfortunately, not able to show in this presentation because I think it would add a lot of details from a very interesting and not so regular case.
Pedro, thank you for your comments. The Dr. Edson Lobo is out of line, and I have some questions from the audience. In the same issue, Dr. Jacqueline Menezes asked for you, in this case, in this special case, do you think the neoadjuvant therapy is someplace or not?
From the first treatment or the second treatment? I will keep going. From the first treatment, maybe we could use neoadjuvant treatment. I like to offer neoadjuvant treatment for most of my patients. When I see the local advanced pancreatic cancer, or when I see a borderline, and even some resectable cases, I think we can offer neoadjuvant therapy. This patient has some clinical features that could show us neoadjuvant therapy could be skipped, like a low CA19-9. He always have the tumor marker below 200. So I think we could skip the first neoadjuvant therapy. On the recurrence, I chose not to use neoadjuvant therapy because I really would like to give this patient no systemic treatment. Since we have only local recurrence, and even after 6 weeks, the recurrence was diagnosed, I have no metastatic disease. I chose to observe and see the biological behavior. How this tumor behavior, sorry. So I was trying to leave this patient with no chemotherapy because of the neurotoxicity he had on the oxaliplatin, and thinking about his profession. He is a lyric singer and photographer. So the neuropathy was impairing his ability to take pictures. But since CA19-9 didn't fall the way I expected it, I chose to give some adjuvant, very controversial treatment here.
Okay. I have another question from the audience for Dr. Thilo. Dr. Thilo, which case are you indicating reoperation in adenocarcinoma of the pancreas?
Well, this is a good question. I think this was a very nice case with a very advanced indication for the resection of the recurrence, because recurrence resection with these vascular resections is pretty rare. We do it sometimes, but also very rarely. And I think it was just what was mentioned. You have some patients who seem to have some kind of local only tumor, which after 2 years, 3 years, just have a local problem, but no metastatic spread. We don't know why. That was mentioned already. And I mean, in these patients, you should do all you can do for the local control. And still, I think surgery, if possible, is the best you can do. If surgery is impossible for some kinds of vascular things you cannot reconstruct or else, then we sometimes consider local ablation like IRE or RFA or something like that. But usually we try to do it surgically, sometimes combined with intraoperative radiation, if possible, but in these local only recurrences, yes.
Another question for Eber Salvador is about the, first of all, he congratulates them, a beautiful dissection. And the question for all surgeons is, what about gastric stump, venous drainage? What do you do about this question for Dr. Thilo and the other surgeons?
Well, if I can comment on this, this is the major problem. And also in this case, I saw that this was the problem that was being foreseen in some way. If we preserve part of the stomach, as you have also done, we do a endoscopy planned on day 1 and day 2, just to check if the venous drainage is fine. Sometimes you don't need to reconstruct. Nobody knows why. Probably some esophageal veins that are still working because you have taken away the spleen, you have taken away the left gastric vein, the coronary vein. Sometimes we try to reconstruct the coronary vein. If we really have a bad feeling during the operation, we take out the stomach. But we have, of course, experienced stomach ischemia after these types of operations and have needed to do a second one with a completion gastrectomy, which of course always is a big second hit for the patient, which we should definitely try to avoid.
Some comments, Eduardo.
I would like to
some
comment.
Comments,
No, thank you.
Please.
Thank you, sir.
Nice, very nice case. It proves that complex arterial resection and reconstruction can be performed. We have just to select which cases should we do it. I think it was a very good case, very interesting. And just regarding the question about venous drainage, I try to do in this case where we cannot preserve or reconstruct the coronary vein to perform a more extensive gastric resection on the first resection, because the drainage will be performed by periesophageal veins. So if you have a lesser gastric stump, I think we should have a better drainage and less risk of complication. I have experienced myself also this kind of ischemia due to venous congestion after extensive resection.
Do you have some comments, Eduardo, or another surgeon, please?
No comments. I think congratulate the surgery. It was a beautiful procedure, and the gastric stump problem, Alexander just pointed very well. If you cannot reconstruct the vein, and then you have to resect more stomachs. There's no doubt about it.
Okay. Question about. I have another question from the audience about what factors influence the upfront surgery and the upfront surgery decision.
Sorry. Alô? Hello?
Fala, Edson, estamos te ouvindo. Você está ouvindo a gente?
Sim, yes, I'm hearing you now. I'm listening.
Now, at this moment, I will have some questions from the audience, from the panelists.
Okay. You can go on. Okay.
And the last question is, what factors influence the upfront surgery decision in this patient? I don't understand really this question, but I imagine that the influence of the stratification or the other things about the concern about the mass in the body of the pancreas. Could you respond to this question, Edson, about your case?
No, your connection, my connections are very bad. I couldn't understand the question, but I would like to have Dr. Eduardo, if he is present. I don't know if he could hear the question. Eduardo?
I don't know.
Yeah.
I think Eduardo is not.
I think I can comment something about it. I think the question is regarding the indication of neoadjuvant therapy or surgery upfront. I think
Yes.
this was the team. I think when we have adenocarcinoma of pancreas that's clearly resectable, and we have low CA19-9 and clearly no evidence of metastatic disease and nothing like that, we can think about the surgery up front. It's very difficult nowadays to choose from the clearly resectable pancreatic cancer when we will go. Sorry, I have some incoming call here, but
okay,
my connection is still going. When we have the clearly resectable adenocarcinoma of pancreas, we always discuss in a multidisciplinary fashion about surgery or neoadjuvant therapy. And we don't know the clear pattern or the clear conceptions to go over one or the other treatment. I think we have some trials that say when you have a clearly resectable, go for the surgery. This is the standard of care. I like to try the patient and the tumor with chemotherapy and to see in vivo if this tumor will respond. Because if I have no response in the chemotherapy and the neoadjuvant setting, I can shorten the exposure of chemotherapy to my patient. But sometimes we go straight from the surgery, like when we have high bilirubin level, because if I will not have surgery up front, I will need to drain the biliary and wait until the bilirubin lowers, so I can delay the surgery and the chemotherapy and offer no treatment, losing my intention of curative treatment. I think those are the things we takes.
Okay, Pedro, thank you for your comments. Edson, I think you called Dr. Eduardo. Eduardo Ramos is with us.
Yeah. Eduardo Fernandes.
Okay.
Okay.
Eduardo.
Hello.
Hello.
Can you guys hear me?
Yeah.
Yes.
Well, first of all, thanks for the invitation. It's a great honor to participate. And this was a very funny case, and yeah, it was a funny case, by the way, because this is a complex surgery, and combining arterial and venous resection are demanding. As you know, these are not easy cases, and we use the cadaver graft to reconstruct the liver. And we have a pretty good experience with arterial resection nowadays. So there are a few questions on the technical aspect that we should discuss, and the first one is what kind of graft can we use in that scenario? Because we can use, like in this case, we use donor fresh graft. So this is an option. And the Asian surgeons, especially the Koreans and the Japanese, they documented a huge experience using those grafts in living donor liver transplant. So we have to make a special care because if you use incompatible HBO grafts, there are more chances to thrombose. So this is a point. And we have few cases, I can say maybe 4 or 5 cases, that we use the donor, the patient, the native saphenous vein to reconstruct the hepatic artery. And I tell you, this is a very good graft because it's easy to deal with. There is a long patency rate, and you can use directly on the aorta or also from the SMA. And the matching size is perfect. So usually the hepatic artery matches perfectly on the saphenous vein. So the type of the arterial reconstruction, it's very important. So in this case, we also had the chance to reconstruct the left gastric artery. That's not usual. Thilo Hackert is here, and I mean, I visited Hidelberg a couple of years ago, and I asked Professor Buscher at that time, and they prefer not to reconstruct the left gastric artery because it's demanding and very tiny artery. If you don't have experience with small vessels and experience with microvascular reconstructions, it could be a potential problem. So on the technical aspects, that is important. And another thing that I recommend is when you combine arterial and venous resection, it's better to finalize the arterial and the venous resection at the very end of the procedure. So you can combine both. You can resect the artery and the vein together, and then you do the vein or the artery, whatever you're going to be easier. But it's important to make sure that all the specimen is ready to take it out from the abdomen, because if you cut the arteries and then you're going to still dissecting tissues around, it's going to lose time. So, and if you're gonna last more than 30 minutes or say 25 minutes to make the reconstructions, it's better to clamp the SMA for 10 minutes, because and then you avoid congestion on the small bowel. So that's a technical aspect that I really recommend. And regarding to the new adjuvant treatment, I think in my practice I try to use case by case. I don't do that routinely, and I discuss with the patient. It's pretty much the patient's decision in combination with our oncologist and our surgical approach. Well, that's only a few things that I want to point out. Thank you very much.
And you don't use artificial prosthesis?
No, I don't recommend it. I don't recommend it. I think you have more thrombosis, and we have, as I said, saphenous vein is a very important graft. So PTFE graft in veins, I don't think we should use it. We have extensive experience in vascular reconstruction, vascular resections in pancreatic adenectomies, and I don't think it's a good deal. I really don't think it's a good deal. I know even in Heidelberg, Thilo is here. I've been seeing a lot of cases in Heidelberg that they use PTFE grafts. I think we have natural grafts. We can use nowadays the peritoneum. We have many cases now collected with peritoneum, phosphor ligament, and the left renal vein is a perfect graft for the veins. For the vena cava, you can open the left renal vein and use as a patch. But if you don't have anything, I mean, it's going to be my last choice.
Okay. Eduardo, I would like you to comment on 2 aspects of these arterial resections, especially involving the superior mesenteric artery. About 2 complications, 2 postoperative complications. One is diarrhea, and the other is the ischemia of the stomach. You used, in this case, hyperbaric treatment for the ischemia, and it worked. and you use the loperamide and pancreatic enzymes to treat diarrhea, and it worked. Would you comment something about these two treatments for these complications? Because one of the complications, that is diarrhea, is a very, very bad complication. The patients have a bad quality of life after these resections, arterial resections, and it seemed that he had a good response to these treatments. Please.
Yeah, that's a good point. And nowadays, my thinking of the radical resection for pancreatic adenocarcinoma is, if you do a curative resection in a pancreatic cancer, if you don't have diarrhea, the operation was not good enough. Diarrhea is mandatory for a good operation. So if the patient don't have diarrhea, you didn't do the good operation. So the total mesopancreas excision today is mandatory for adenocarcinoma.
Nós só temos mais 7 minutos, tá, Edson?
I am finishing. Just
viu? Você viu? Nós só temos 7 minutos.
Tá legal. Okay.
So, as I was saying, diarrhea it's universal in the total mesopancreas excision. If you don't have diarrhea, the operation was not adequate. So I expect diarrhea in every patient. And loperamide, it's like a routine. Every patient has loperamide for 2-3 months, and they recover. If you have like a very bad diarrhea, like 15 episodes per day, and then it's going to be bad. But usually the patients have 4, 5, 6 episodes of diarrhea, and they go well with the loperamide. So I don't think it's an issue. Hyperbaric oxygen therapy, we have experience in liver transplant scenario and in pancreatic leaks. I think it's very good option, because you oxygenize the tissues around, and it's good to replace, you know, the oxygen and the healing around some possible ischemic areas.
Okay, thank you. Well, I would like to ask Dr. Thilo for some comments, final comments, because we are our time is in the end. So, Dr. Thilo, would you like to comment anything about those?
Just a brief comment, Eduardo. You mentioned exactly the right thing. We have now looked at our portal vein resections, and we have seen that the PTFE grafts are actually not the best you can choose. We have a short-term thrombosis rate of approximately 20% in these patients, and nowadays we try to avoid this whenever possible. As you said, end-to-end left renal vein, something like that, is probably much better. We have probably learned something in this respect.
Would you like to comment on this recent publication about the types of duodenopancreatectomy on surgery?
Yes, of course.
21. It's very interesting, because you put 4 types of duodenopancreatectomy.
Yeah, we just wanted to make this a little bit more comparable, because you have a standard Whipple, you have a Whipple with vein resection, you have a multivisceral Whipple, and you have a Whipple with arterial resection. So this is distinctly different, and you have a higher risk of your complications, so you should be aware and not just report, I have done 200 Whipple procedures or something, and my morbidity was, my mortality was, but you could really subclassify, and then you know what to expect in this distinctive collective of this specific type of Whipple. That was the idea of this publication.
All right. And just to comment, for the type 4, that arterial resections, you have only 1% of the cases, right?
Yes, that's right, because we are very liberal in doing a total pancreatectomy when we do arterial resections with a major reconstruction, because we are still a little afraid of the fistula and the bleeding, and then we really liberally take out the pancreas, and we are now just having accepted the same classification for the total pancreatectomies in JAMA surgery. This will be online very shortly, and there you can see that you have total with arterial. This is also some kind of morbid and also mortality complications, but this is what we do very liberal when we do a major arterial reconstruction.
Thank you very much. I'm sorry for the time.
No, the time is good. And thank you for your comments. Thank you for all comments of all panelists. Then I would like to congratulate for the excellent case. And now we'll move on to the presentation to the AC Camargo group with a case about non-functioning net of pancreas, which will be presented by Dr. Alex Barbosa and moderated by Dr. Felipe Coimbra. In the debating with Gabriel dos Santos and Silvio Melo Torres. And Felipe,
hello.
Alex.
Hi.
Okay.
Good morning.
Okay.
Good morning, everyone. Thank you, Celso. Thank you, everyone. Thank you from the Pancreatic group from Brazil. And we are very honored to be here today. We are going to present about neuroendocrine pancreatic tumors. And we decided to do a little bit different with 2 or 3 cases, very small, with just some discussion between the cases. So we have today Alex, which is our fellow from Esse Camargo, from his 4th year of residence. Silvio Melo is a surgeon, Gabriel pathologist, Mauro, and maybe at the end we will have one of our friends from Miami, but I'm not sure because of the time if he'll be able to come early. So now I invite Alex to start the discussion. Thank you. We're going to try to keep on time. So during the discussion, please also let me know, and I will try to be on time.
Bom, bom dia a todos. Como eu tinha comentado com o Dr. Celso e o Dr. André, a apresentação vai ser em português, acabamos que não nos preparamos para fazer a apresentação em inglês, mas vou tentar sintetizar os principais dados que estão em inglês aí nos slides para os convidados estrangeiros. Obrigado, Dr. Felipe. Bom, como ele falou, trouxemos 3 casos com diferentes cenários. O primeiro caso é uma paciente do sexo feminino de 49 anos, uma paciente assintomática, onde foi evidenciado um nódulo pancreático, sem outras queixas. A paciente de histórico prévio tinha um esôfago de Barrett, epilepsia e uma hipertensão arterial. Aqui no exame de imagem, na ressonância, a gente evidencia uma lesão no processo cinário na cabeça do pâncreas, uma lesão de 2 centímetros, sem ausência de linfonodo ou dilatação do ducto pancreático ou do colédoco. Aqui, seguindo a fase da ressonância, um T2, a imagem vai se repetir. Aqui, novamente, fase T2. Aqui a fase arterial da ressonância. Mais uma vez, a gente vê um realce na lesão, realce periférico. Aqui, então, aqui a gente tem essa lesão no processo cinário de 2 centímetros, à esquerda a fase arterial e à direita a fase venosa, evidenciando essa lesão. E nosso questionamento agora seria, diante desse caso, qual a melhor conduta no momento? Uma biópsia guiada por ultrassom endoscópico, partir para uma cirurgia de upfront ou seguir com watch and waitful? Dr. Felipe?
Eu vou deixar para os debatedores ajudarem na discussão, mas, por favor, quem puder falar, a gente só vai ter que, talvez, cortar um pouco a discussão para poder andar com o caso, né? Então, vamos ouvir já. Sorry, let's know the idea from Celso. So the idea is a neuroendocrine pancreatic tumor in the uncinate process with about 2 centimeters. So what would be the next step? Endoscopic ultrasound, surgery up front, wait, because there's another possibility with this size of tumors.
The first thing to do is if this lesion is a cystic lesion or not. if it is a cystic lesion, I think the best for the patient is the surgery. But if the lesion is a solid lesion, only solid lesion, I performed in this patient AUS, not FNA, but FNB.
So FNB, you mean there's a larger
yes,
biopsy,
FNB
right?
with, for example, core biopsy. They
Yes,
are in
okay.
the market now. There's some different kinds of needles that permits more extension of tissue and more the better results to immunohistochemistry, for example.
Okay, so let's see about Professor Chillers. Are you still there? Could you give your options in Hidelberg? What do you do in this situation?
Yeah, probably with 2 centimeters, we would go for surgery. I mean, between 1 and 1.9, we would consider biopsy or maybe even watch and wait. If it's 1 centimeter, but I mean 2 centimeters, we would clearly see an indication for surgery, just because of possibility of lymph node metastasis and things like that.
Yeah, and do you do echo endoscopy? Endoscopic ultrasound? We find
yes, we do.
To see KY.
Yes, we do that, but of course we know that these tumors are often not homogeneous. Depending on the lesion, where you hit the lesion, you might have a different KI than you have somewhere else. So I think there is some kind of uncertainty in that.
Yeah, sure. So is Gabriel there? Gabriel tá aí? I'd like to hear from.
Eu estou aqui.
From Gabriel, a pathologist, just to understand how difficult it is to establish the KI 667 and some features from the pathology. Very short, please.
Yes, the great difficulty is where what was the site of biopsy. We have a very large difference inside the same tumor. And some place we can find a KI 67 for 15%, and in the other side we can find a KI 67 of 5%. And this is one of the pitfall that we pathologists can be misfortunate.
Okay.
This is we choice for the biopsy by ultrasound.
Yeah. So vamos seguir então, Alex. Let's follow the case.
May I?
Hello. Yeah.
Well, after FNB procedures, we have a very close Ka67 on the biopsy and the surgical specimen. And you have to consider that one of the differential diagnoses of this very sharp nodule is serocystadenoma. So I think biopsy is mandatory before surgery. I'm a pathologist, I'm sorry.
Yeah, yes, now we know. Thank you, Philadelphia. Okay, so let's follow the discussion, have more opportunities for...
A gente trouxe esse artigo aqui para mostrar o papel do ultrassom, da biópsia por agulha fina do ultrassom endoscópico nas lesões menores que 2 centímetros, onde nesse estudo 314 pacientes foram submetidos a ultrassom endoscópico com biópsia agulha fina. E como já foi dito pelo Gabriel, nesse caso, apenas 26,4% dos pacientes conseguiram ter a diferenciação tumoral identificada e 20% o KI67. Quando esses pacientes eram realizados biópsias e iam para o procedimento cirúrgico, teve uma concordância entre a biópsia e o procedimento cirúrgico na diferenciação tumoral, 81%, e no KI67, 92,7%. E nesse estudo ficou um pouco lento. No estudo foi evidenciado que o ultrassom endoscópico com biópsia por agulha fina consegue confirmar o diagnóstico histológico nessas lesões menores que 2 centímetros em 73,2% dos pacientes. Então, essa paciente ela foi submetida à biópsia por agulha fina guiada por ultrassom endoscópico, onde a gente obteve mais características, era uma lesão sólido-cística de 22 milímetros, com um componente cístico de 7 milímetros, confirmando uma neoplasia neuroendócrina com KI67 de 15%. Agora, nesse momento, mudaria a conduta de alguns colegas? O que é que a gente faria?
Alex, yes, thanks. I think we already did the discussion. So I don't know, Silvio would like to say something just to...
Yeah, in the moment of the diagnosis, this specific case, the best choice, in my opinion, is surgery in the moment.
Yes, I think we discussed this already, so let's follow with the presentation. Vamos seguir, Alex.
Certo.
Felipe, only one comment. I think in this case, for example, with this pathological findings, I indicated in this patient at surgery.
Yeah.
I think that at this moment, the best option for this patient for the management is the surgery.
Yes, exactly, because it was already larger than 2 centimeters, grade 2.
But always based on these pathological findings.
Yes, actually, even though if we didn't have the pathological findings, it would be surgery too, because of the size and the suspect lesion. But yes, but now we have both corroborating with the same indication. I agree. Yes.
Yeah, I agree. Yeah.
Bom, seguindo, como o Dr. Celso comentou, mas um caso semelhante, sendo um tumor neuroendócrino com um tamanho de 18 milímetros e um KI67 de 2%, mudaria a conduta nesse caso? Ou manteria a cirurgia?
This question
would be a different situation.
This question is for me.
So this would be a different situation.
I wait. In a case like that, I wait the evolution of this patient.
I
the AUS or MRI.
I ask some people just to say, operate, yes or no, and then we are going to follow, okay?
No.
Okay, so, Celso, no. Wait and wait. Okay, Professor Thilo.
Would operate.
Operate, okay. Professor Ademar. I don't know if she's here. Professor José Cunha.
Yes,
Eduardo.
Operate.
Okay, who else? André de Borix.
Surgery as well.
Okay. So I think surgery is winning so far. Let's see, but this would be a possibility. Depending, I think that's not only resectable or not, but maybe the age of the patient, comorbidities, risk of the surgery, and other factors, of course. For example, for me, it would be different from a 20-year-old boy or a 70, 80 with a lot of comorbidities for the same lesion size. So yes, but very good, different situation, and sometimes we deal with this in our daily practice. So okay, so Alex, let's go.
Vamos seguir. Então, a gente trouxe alguns estudos aqui só para acrescentar à discussão. O guideline da ESMO de 2020, da Sociedade Europeia de Oncologia, ele orienta que é seguro fazer o acompanhamento nesses pacientes que são a lesão T1, ou seja, menor que 2 centímetros, sem linfonodo acometido e sem sintomas ou não funcionante. Ele recomenda que é seguro fazer, sim, o acompanhamento desses casos. Aqui outro trabalho publicado por Bartelli, e foi uma meta-análise de 5 estudos retrospectivos, onde 540 pacientes, 60% foi submetido a active surveillance, 39% a cirurgia, e os pacientes que eram acompanhados, eles podiam ser submetidos à cirurgia quando atingisse uma lesão maior que 2 centímetros, fossem sintomáticos ou apresentasse linfonodo ou dilatação do ducto pancreático principal. O tempo médio de segmento desses pacientes que foram diagnosticados até do Active Surveillance até virar o grupo cirúrgico foi de 30 a 41 meses. E os principais motivos pela cirurgia foi o aumento tumoral em 19 pacientes, sintomas em 2 pacientes, mas o que ficou evidente nesse estudo é que não houve nenhum caso de morte relatada no grupo Active Surveillance, e o estudo sugere que é sim seguro fazer o acompanhamento desses pacientes que têm tumor neuroendócrino não funcionante menor que 2 centímetros. Só para ilustrar o nosso caso, então, a lesão sólido-cística, a gente trouxe essa revisão sistemática, onde avalia o comportamento biológico dos tumores císticos versus tumores sólidos. Eram 355 lesões císticas e 1.530 lesões sólidas, onde os homens eles eram mais prevalentes nas lesões císticas e as lesões císticas estavam mais relacionadas às neoplasias endócrinas múltiplas. E a gente viu que as lesões císticas ela tem menos relação com metástase à distância, menos acometimento linfonodal, menos invasão vascular, como invasão perineural, e também um Ki67 menor que 2% era mais encontrado nas lesões císticas, como também o índice mitótico. Mas não foi evidenciado a diferença na sobrevida global de 5 a 10 anos, e na sobrevida livre de doença, as lesões císticas elas têm uma sobrevida livre de doença maior em 5 e 10 anos também, como foi visto nessa revisão sistemática.
So I think, as we discussed, I think both situations may be right, but in some cases, it depends on some other factors. We may have the chance to observe some of these cases depending on many other points here. But I think, remember, in general, most of these studies are not so long-term if we consider that we are talking about neuroendocrine tumors, especially low-grade ones.
May I ask a question? Sorry about interfering in another table.
Yes, go ahead, Pedro.
Yes, go ahead.
Okay, as an oncologist, I think my chance would be surgery, active surveillance, maybe with a very long discussion. But I would like to ask something very controversial. What do you think about neoadjuvant therapy for neuroendocrine pancreatic tumor?
Yeah, Pedro, we are going to have the chance to discuss about this in the next one case. So if
Sorry.
So if you could wait a little bit, we're going to discuss it. Thank you.
Bom, só para dando seguimento aqui para falar que tem sido realizado aqui um trabalho na revisão da literatura de radiofrequência guiada por ultrassom endoscópico, onde foi avaliado 12 artigos, 73 tumores neuroendócrinos, com a média do tamanho de 16 milímetros. Vale ressaltar que no segmento médio de 11 meses, 96 pacientes tiveram a resposta com radiofrequência guiada por ultrassom, com necrose ou resposta completa. E o tamanho do tumor em si, ele vai dizer o desfecho da resposta do tratamento. E aqui na curva ROC ele propõe um cutoff de 18 milímetros para esses tumores neuroendócrinos que poderiam ser seguro realizar radiofrequência guiada por ultrassom endoscópico. Então, é uma paciente de 49 anos, COG 0, com um tumor neuroendócrino de 2 centímetros no processo assinado, com Ki67 de 15%. E a gente realizou um PET com galho nessa paciente, onde mostrava uma captação única com SUV de 34. E a paciente ela foi submetida a uma gastrodiodenopancreatectomia. E o anatomopatológico final foi uma lesão de 2 centímetros, com 3 mitoses em 10 campos de grande aumento. E, diferentemente do Ki67 que veio na biópsia anterior de 15, veio um Ki67 no AP final de 40%. Uma lesão grau 3.
Yes. So, I don't know if Gabriel wants to talk about this different immunohistochemistry on Ki67. Is it common? How difficult it is to establish the right one?
Honestly, this is not so common. This is a particular case, and we need to think that how much tissue was taken in the biopsy, and we have inter-observer discordance when we do this type of measure in percentage. What I think is when we have the entire surgery entire surgery piece, we can choose the best amostrage for to do the immunohistochemistry. Then we choose the mineral difference area, and we can find a CPI-67 more higher than the original biopsy. This is what I can find as a explication for this discordance.
Ok, vamos seguir, Alex.
Então, seguindo para o caso 2, uma paciente também de sexo feminino, de 44 anos, uma paciente que era sintomática, também teve um achado incidental no ultrassom, sem outras queixas, um CA19,9 de entrada de 22 e um CEA de 1,2. A paciente foi submetida ao exame axial, onde mostrou uma lesão de 7 centímetros, uma lesão sólida expansiva na cabeça do pâncreas, com um contato de pelo menos 180 graus na veia porta, também na veia mesentérica superior. Só que nesse caso não era apenas uma lesão localizada, a paciente tinha uma lesão hipervascular no segmento 6 de 12 milímetros, suspeita de metástase da lesão. Aqui é a ressonância do paciente. Seguindo, uma lesão volumosa, suspeita da lesão no segmento 6. Essa paciente ela foi submetida a uma biópsia guiada por tomografia, onde evidenciou uma lesão neuroendócrina com KI67, aqui no caso de 7%. Foi realizado um PET com TG, a paciente não teve acesso ao PET com galho, com SUV de 6,7 SUVs. Nesse caso, diferente do outro, a paciente com uma lesão metastática suspeita no segmento 6, qual seria a opção de tratamento dos colegas?
Silvio would like to comment, and maybe one or two of our colleagues.
Yes. In this case, we had a live biopsy, but it was negative.
The negative biopsy from the liver?
The liver, the nodule, hepatic nodule. I would
Okay,
like to...
so
Mauro is here?
yes. So yes,
Oh,
now you can. So you have a local advanced tumor with suspect liver metastasis. So maybe a more advanced situation here, and I have our medical oncologist here, so we can discuss also with Pedro. And so before Mauro could wait a little bit, let's hear from the surgeons, their opinion.
Right.
Then you and Pedro will help us to understand the best situation here. So let's
right.
see. So Professor Thilo, so it's a neuroendocrine local advanced one with a liver metastasis, a low volume disease in the liver. So in this situation, would go for upfront surgery, or would you try or discuss maybe some neoadjuvant therapy here?
I think there's two aspects. The one thing is I could not see the superior mesenteric vein on the MRI if this would be reconstructible or not. Probably it was. And the second thing is the KI of 7%. I think this is something where you can do surgery, do an ultrasound of the liver intraoperatively, and this would be just a small atypical resection. Then you have a probably radical resection, and then you can wait what happens. That would be my suggestion in this case.
Yeah, so yes, just answering. And so this is a technically resectable and reconstructible lesion from the vein. So that's exactly this situation technically. So let's see who else would like to comment. Maybe Lobo, Edson. Who else is? I'm not seeing everyone. Let me see.
In this case, I believe the systemic treatment gives us time for understand the biological behavior of the disease and decide by surgery at the moment.
Okay. Yes. Yes. So let's see. Mauro, please give us your suggestion and opinion in this case.
Well, in pancreatic, well differentiated non-direct tumor, chemotherapy is the benchmark. If the main treatment goal is the reduction of the tumor mass, particularly if you would allow secondary surgery. So yes, I would start with chemotherapy for this patient to allow a reduction of tumor mass and allowing the secondary surgery.
And what kind of chemo or scheme of systemic treatment would you use most commonly in these situations?
Well, we don't have this answer very clearly in the literature, but in the old times you use streptozotocin and doxorubicin, but they are renal and cardiac toxicities very respectively very high, and so we started to use fluorosilbacarbazine and capecitabine and temozolomide, and we achieve better response rates. Some trials showing that using Captan, you can achieve more than 50% of response rate. So nowadays, we have to see the patient and see comorbidities and manage all the toxicity in each patient. But I would go with Captan.
Felipe.
Okay.
I'm receiving a lot of messages from Susan. I think Susan would like to ask something.
Sure.
Susan?
Hi. It is very common to find some small lesions in the liver, especially those hypervascular ones. I think that is very, very important to differentiate between benign small lesions and metastases. I think we should carefully look for DWI and perform a primo vista exam, because those lesions are sometimes concurrent with a finding of any kind of tumor, and they are not especially very, very, it's not difficult to differentiate them.
Yes. Thanks, Susan. Very important. So sometimes, especially with this MRI, we can see very small lesions that sometimes you can't differentiate from benign ones. So very important. So by that time, I believe it was discussed with our radiologist, and still the lesion seemed very suspect. So we decided to face it as a metastatic lesion by that time.
Okay.
But very important. So you're gonna see the continuation of the case too. Sylvia, would like to comment anything and some more details from the case?
Felipe, Alexandre Rezende, Felipe, posso fazer um comentário rápido?
Claro.
My comment would be, I wouldn't think of a neoadjuvant therapy for a patient with 50% rate of response, expected response. It's a resectable lesion at this moment, and we will have, if a low experience, there are not a large number of cases with neoadjuvant in this situation, but if we are in the context of 50% of response rate, I wouldn't consider a drug of 50% for a lesion that is resectable. And for the hepatic lesion, it's a subcapsular, easily taken off. It wouldn't be a problem, in my opinion.
Yes. Thank you. Yes, we have to be very careful with these cases. We should consider all the context, so the patient fit for that moment, the tumor, the surgery, the extension of the surgery, and so I'm gonna follow the discussion, see more details then.
Tive problema no computador, mas voltou aqui. Só minuto, vou reabrir aqui a aula.
while we are waiting, I would like just to say something very quickly.
Sure.
I know some retrospective data showing us that neoadjuvant therapy for PNET can lead us to a better PFS and even some small data showing better overall survival. All this data is retrospective, of course. We don't have any prospective paper about this setting. On PubMed today, we have about 70 papers with neoadjuvant therapy for PNET. So it's a very unknown space that we are talking about. But I would like to give this patient CAP-10 for neoadjuvant therapy.
Pode continuar, Alex.
Sim, para continuar, não sei,
Di,
retomando a discussão.
vai ter futebol. Se você quiser descer bem de leve. 10h30.
Essa paciente, ela... Estão me ouvindo?
Estamos, perfeito.
Sim, Alex.
Certo, então a paciente ela foi submetida à quimioterapia, realizou 4 ciclos da carbazina com ciclofluoracil, porém nos exames de segmento a paciente teve progressão de doença, aumento do tamanho da lesão e do nódulo hepático, e foi optado por mudança do esquema de quimioterapia para fulfirinox modificado, sugerido 12 ciclos, onde a paciente segue com doença estável. Depois de realizar a quimioterapia, ver o comportamento biológico da doença, onde se encontra estável, o que seria melhor nesse momento para ela? E comentar, doutor Felipe.
Yeah, so it was decided in a tumor board to follow if some chemotherapy due to patients' clinical condition and other features from the tumor by that moment. It is very controversial though. Let's see, Mauro would like to do a last comment on this chemotherapy and these schemes for treatment.
I think the important point is this case is stable disease.
Yes, true.
Yes, when we decide to perform such a triplet chemotherapy for a patient with grade 2 neuroendocrine tumor, we are looking for some hair control than we usually look for, because probably this patient presented a higher aggressive behavior of the disease. Depending of the pattern of the progression of disease, we use this triplet such as FOLFIRINOX rather than somatostatin analogs. But once it reaches a stable disease and we know that we cannot keep going FOLFIRINOX, so we could change the treatment for a maintenance treatment with somatostatin analogs such as lenalidomide.
Okay. So I think by this time, let's see, Alex, please go ahead with the case. We're going to have some more chance for discussion on the next one.
A gente trouxe alguns artigos para discutir o benefício da cirurgia nesses pacientes com tumores neuroendócrinos metastáticos. Essa revisão sistemática aqui, onde 56% dos pacientes tinham tumores acima de 4 centímetros e 44% dos pacientes eram pouco diferenciados. Na avaliação dos fatores, na ONU multivariado, a cirurgia foi um impacto favorável na sobrevida, enquanto a idade, principalmente acima de 60, e o grau do tumor pouco diferenciado foram deletérios na sobrevida global do paciente. Aqui a gente vê no gráfico de sobrevida global, na análise do gráfico de sobrevida global, comparando os pacientes que foram submetidos à cirurgia dos pacientes que não foram realizados nenhum tipo de procedimento cirúrgico. A gente vê uma sobrevida em 5 anos de quase 60% do grupo da cirurgia, enquanto os pacientes que não foram submetidos a nenhuma cirurgia com a sobrevida de 20%. Dos pacientes que tinham condições cirúrgicas e não foram submetidos a cirurgias por algum motivo, principalmente aqui nesse trabalho que foi a performance status, eles apresentaram a sobrevida global igual aos pacientes que não tinham condições cirúrgicas por questão tumoral. Então a gente vê que a cirurgia ele traz sim um benefício na sobrevida desses pacientes mesmo quando metastáticos. Aqui esse outro trabalho...
Pode seguir, Alex.
Só seguir com esse outro trabalho. Esse outro trabalho ele trouxe para a gente a relação o desfecho dos pacientes que eram submetidos a pancreatic duodenectomia com metastasektomia, comparando com os outros grupos onde o paciente era só submetido a duodenopancreatectomia ou só a metastasektomia ou nenhum procedimento cirúrgico. A gente vê aqui que 52% dos pacientes eles foram submetidos à ressecção do primário com a metastasektomia, e na análise do gráfico da sobrevida acumulada, a gente vê que a cirurgia com a metastasektomia, ele tem ganho sim na sobrevida, até em relação, se você pegar aqui os pacientes que foram só submetidos à cirurgia do primário ou só submetidos à metastasektomia, tiveram ganho de sobrevida em relação aos pacientes que não foram submetidos a nenhum procedimento cirúrgico. Aqui na análise multivariada, os fatores como pancreatectomia, centros de alto volume e metastasektomia foram fatores preditores positivos para a sobrevida, e idade acima de 75 anos e alto grau como deletério, fatores deletérios. A mediana de sobrevida dos pacientes submetidos à cirurgia do primário foi de 63 meses, quando comparado aos pacientes que não foram submetidos à reseção cirúrgica de 10 meses. Essa paciente ela foi então submetida a uma duodenopancreatectomia, onde foi evidenciada uma lesão de 6 centímetros, com 3 linfonodos de 29 positivos, um PT3-PN1, com um KI67 que era de 7%, veio de 3% na peça final. E desfecho essa paciente foi seguida ambulatorialmente, 11 meses já de follow-up depois da cirurgia e sem evidência de doença nos exames axiais.
During the surgery, we had a ultrasound liver and we didn't find the hepatic nodule. So we decided for continues the duodenopancreatectomy.
So one comment here. So during the surgery, there was no lesion, Susan. So what's your main hypothesis? So the lesion disappeared after chemotherapy, or there was no lesion at all?
Well, this is very difficult to say because
These are very important points. So I'm glad you raised it before, because we don't know either. So, but it's important to have this in mind also.
What I have to say is that we follow a lot of this kind of patients and all these lesions are really, really very difficult to differentiate. Really, really very difficult. Sometimes you look for the lesion in one spot and you say, no, this is definitely a metastasis. And in the other exam, like 2 months later, you look at the lesion and you tell yourself, wow, how could I tell this is a metastasis? Then it's a complex subject, and I think that we have to stress, we have to talk about this, but we definitely don't have an answer.
Yes, and we are very worried sometimes when we operate these patients with some hepatic lesions, that usually, not in all cases, but usually we find some additional ones. So sometimes we see 2 or 3. So during the, of course, nowadays much less with a good MRI, but usually we find new lesions, and so we are very worried about that. But fortunately, we had a good result on the liver, at least here. So, but we also found some positive lymph nodes that it wasn't very clear in the preoperative exams. So let's see from Gabriel if he has some comments on the pathology.
Yes, Felipe, this is a more common finding. When we institute chemotherapy and somatostatin analogs, we find a Ki67 lower than the original biopsy. This is a very common finding.
Good. Okay. So, anyone would like to make a comment or?
I'd like, Felipe. I was very happy when Susan asked and raised the suspect of metastatic disease despite the biopsy, because it really can happen. And neuroendocrine tumor is a very heterogeneous tumor. And once again, this patient didn't have access, but somatostatin scintigraphy scan would help us a lot, because this patient presents a very low-grade neuroendocrine tumor, and gallium PET or scintigraphy would help to ask these questions. When you could go to the surgery more prepared to avoid the liver metastasis.
Yes, very, very important model. Thank you. Any other comments on this case?
Was there any vascular invasion?
Silvio would like to comment?
No. It was necessary to perform vascular resection. Only there is only touch the portal vein.
Okay.
Only one comment, more one doubt than one comment. KI 67 positive and 3% is a grade 1 or grade 2?
2. Grau 2.
Gabriel, quer comentar?
Because
yes, Gabriel would like to comment on this classification. So it's on the border, yes, José, it's on the border.
The first grade 2. Grade 2 range from 3 to 20. It's grade 2.
Yes, it's a grade 2 neoplasia.
Okay.
But of course, also this is André, this is a very in the limit, right? But formally, it's a grade 2 classification.
Because in the most classifications that you see, this is a grade 1, not a grade 2.
Yes,
because
yes.
This is my doubt.
Is 3 and 20, but of course there is a lot of difference. So a 3 is a different from 19, and 20
Yes.
is different from 90. So of course you have to put all in perspective. But
yes,
I mean formally for the WHO classification, it's already a 2.
Yeah, it is already a grade 2.
Any sign
The
of
problem that we
chemotherapy
have
response on the pathology?
If there is some response on the analysis, Gabriel. Signs of response in the pathology. Did you find anything? Gabriel, it's for you. I think it's not. Yes, not.
Felipe, you hear me?
Yes.
Yeah.
Yes. Was suggested upfront approach by Thilo and Alexandre in this case, and if you have decided an upfront, you think you had performed a peripheral hepatectomy on this nodule or not? The previous nodule in this the MRI that you saw, because we are dealing here with no positive stream biopsy. We got a systemic disease. What would be the surgery?
I think I would just have taken away this little nodule during the surgery, because this is really like a biopsy.
Yeah, this was a very small lesion, a small resection. If we had found only one lesion like that, would be very easy resection. Okay, so let's follow. We have still a very small last case, so we have 7 minutes. So Alex, go ahead.
O último caso, a gente trouxe uma paciente sexo feminino de 39 anos. Ela teve uma perda ponderal de 17 quilos e queixa de dor abdominal. Nesse caso, ela tinha um CA19-9 de entrada de 973. A paciente foi submetida a um exame axial, onde mostrou uma lesão de quase 10 centímetros, onde tinha linfonodo aumentado, também tinha invasão vascular da veia esplênica com trombose, além de acometimento do tronco portal, além de acometimento arterial do tronco celíaco, da artéria hepática, da esplênica e também circulação colateral. Vou rodar a imagem aqui. Uma lesão volumosa, a gente vê a circulação colateral, linfonodos aumentados. A gente vai repetir. Essa paciente ela foi submetida a uma endoscopia onde
So
a lesão
Alex, let's discuss the imaging. I don't know if Susan would like to. I know that the images are not completely here, but from these ones we have already. Would like to comment?
It's a huge hypervascular mass. Whole pancreas is not very well seen. I think that we have a dilatation of the whole pancreatic duct and lots of hypervascular lymph nodes, and the anatomy of the vascular is completely altered because you can see lots of collateral vessels, and it's probably the first thought of my first guess is a TNE, but it's a huge mass with a lot of complex vascular things going, and that's my guess.
Yes, very. So it's invading celiac axis and veins and everything here, and a lot of collateral veins too.
Lots of collaterals. It's a huge.
Not what a surgeon usually likes to see.
No, it's not common to see something like that.
So Alex, go ahead. Thank you.
A paciente foi submetida à endoscopia, onde a lesão ela já invadia a papila duodenal, foi realizada a biópsia dessa lesão. Nesse caso, confirmou uma lesão neuroendócrina com KI67 de 22%, no caso, um grau 3. E, diante desse caso, uma lesão volumosa, KI67 de 22%, qual seria a melhor conduta para essa paciente no momento?
Yeah, so let's see from our colleagues here. So, Professor Thilo, in this situation, what would you do? So, a little different from the previous one.
In this situation, I would go for neoadjuvant treatment, I think.
Yes, usually in your service, you do you have like lutetion or other possibilities, or do captain? What usually would your medical oncologist recommend?
I think usually they recommend some very aggressive thing. I'm not really sure what they would recommend in this patient, but maybe even something that is also good for pancreatic cancer, because this high CA99 was a little bit uncommon, 900 CA99 in neuroendocrine. So they would probably suppose this is a kind of a mixed adeno-neuroendocrine or something like that.
Okay. Mauro, would like to comment?
I think that Thilo raised the question. This probably is a high-grade neuroendocrine tumor mixed with adenocarcinoma due to the higher CA99. So we perform in this case some neoadjuvant chemotherapy such as FOLFIRINOX. We don't treat thinking only on NET because possibly this patient has a mixed tumor.
Okay. Okay, so Edson, were you comment?
No,
okay.
No, it's a very advanced tumor on chemotherapy. The option.
Right. Felipe.
Yes.
Felipe.
Celso.
Felipe, 2 minutes.
Okay. So let's go, Alex, and let's follow a little bit more. Then we have more.
Bom, vou passar aqui, isso é uma análise mostrando as ressecções dessas lesões volumosas, O interessante nesse estudo foi que mesmo essas lesões que acometiam órgãos adjacentes, foi conseguida uma ressecção R0 em 95% dos pacientes. Vou avançar um pouco devido ao tempo. Aqui evidenciando a sobrevida desses pacientes que eram submetidos à cirurgia, sobrevida global de até 66% em 5 anos, ou seja, um valor interessante. E essa paciente ela foi submetida a fulfirinox 12 ciclos com loreotide e ela segue com doença estável. Diante desse caso, uma paciente com um tumor de crescimento lento, sem sinais de metástase, apenas uma doença localmente avançada com essência estável, mudaria alguma conduta depois da quimioterapia com análogo?
So by now we're gonna almost finishing, but I'd like to hear the opinion from Alexandre, who was going to talk something, and some of the colleagues, Professor Thilo. After this neoadjuvant chemotherapy, from the imaging, I think there was not much difference, right? Stable disease, but at least not progression. But you can see it's a local advanced lesion with celiac axis invasion and some lymph nodes on the retroperitoneum. And sometimes the difficulty is to reconstruct here the veins and a lot of collateral veins leading to some bleeding during the intraoperative. So let's see from Professor Thilo what you do, and if you go for operation, what would be your tactics here? What you do first and second in this surgery?
I think the strategy would be to do a portal vein bypass first, to have the collaterals out of the game, and then go for the resection of everything, because this lady is 39 years of age and is ECOG 0 ASA 1. I think this is some situation where you should give everything you can.
Yeah, and the systemic bypass from where? From a collateral to the renal to the cava? What usually you do?
If ever possible, from the superior mesenteric, if you get one branch of it, to the cava first, and then take it out and then reconstruct to the portal vein upwards.
Yes, yeah, we had some experience with this, so we do this now. So this is very useful. So let's see what else. Alexandre would like to comment.
My question would be, I also think this is a mixed tumor, a carcinoma with neuroendocrine, and we had just a small biopsy from the papilla. I would ask the clinical oncologists if they are comfortable to start a FOLFIRINOX without a direct biopsy from the lesion. I would think it wouldn't be interesting to have a biopsy from the mass, from the huge mass, to confirm this suspicious of mixed tumor, and so it will be easier to indicate the FOLFIRINOX scheme.
Mauro, Gabriel would like to comment.
Yes, I am very comfortable in considering a mixed cancer, because the neuroendocrine tumor is hard to determine if it's only a well differentiated or a high grade tumor, if there's neck or net, and if there's mixed. We always seen the evolution of this patient. We always seen other features of the case behind, other than the Ka67. We always watching for the images and the behavior of the disease, the response of the disease to the treatment that we have already done, and even sometimes to several markers such as CA19-9. So I wouldn't mind treating this a mixed tumor, even though showing the biopsy showing just an neuroendocrine tumor.
Okay, due to the time, we can't have a more discussion because of the next presentation, of course. But just to let you know, we still are in this moment, in this right moment, deciding what to do with this case. We have not operated yet. We do think it's possibly resectable. But in some more advanced cases, we even have discussed sometimes multivisceral and very selective transplantation. Not with us, we don't do this. But we think maybe we still have to discuss in some more advanced cases. We have invited Rodrigo Viana to be here, but it wasn't possible because of the time. He was supposed to be a little bit later. But then any other slides, we can't present anything more. But if you like to, Alex, quer passar o último slide?
Só para finalizar, a paciente fez realmente do ciclosorfirinox, terminou em dezembro de 2020, ela passou em consulta agora em junho de 2021. Ela só está com lareotide e mantém a doença estável, não teve progressão do tumor nem sinais de metástase. Só queria finalizar aqui, doutor Felipe, agora na ESMO de 2021 de setembro, a gente está levando nossa casuística de 129 casos, de 1999 a 2020, com os tumores neuroendócrinos ressecáveis de cauda e cabeça. Foi então incluído pancreatectomia corpo caudal, como DPT e GDP, e a gente tem uma análise de uma sobrevida livre de doença de 5 anos, 74%, e uma sobrevida global de 92,5%, na análise uni e multivariada. Os fatores preditivos foram grau 1 como um benefício e KM67 grau 2, lesão maior que 2 centímetros e linfonodo positivo como um fator deletério para a sobrevida livre de doença.
Okay, so yes, that's thank you, Alex. So yeah, maybe on the next Pancreas Club meeting, we're gonna present maybe the results of this last case. We so far are deciding. So thank you very much, thank you all, and yeah, let's go for the next one. Thank you, Celso.
Felipe, thank you very much, Felipe. Thank you very much. Now, thank you very much, Felipe. Now we'll change. Sorry for the time, but now we'll move to the Hospital 9 de Julho group, and we will present two cases of pancreatitis, one asymptomatic and another symptomatic for discussion. I will be the moderator, and the Dr. Tarek will be the presenter. The debaters will be Drs. Paulo Amaral from Bahia, and Dr. Alexandre de Minas Gerais. Tarek.
Hi, good morning to everyone. My name is Tarek Almighty. I am a fifth-year resident from the digestive endoscopy on the Hospital 9 de Julho. And I want to thank to everyone for the opportunity to be presenting today, especially to Dr. Celso Ardengue, the head of the US service on the hospital. Well, today we're going to present pancreatic cystic neoplasia, 2 clinical cases. The first clinical case, it's a female of 62 years old. She's a physician. She was asymptomatic, and one abdominal ultrasound showing a pancreatic cystic lesion. CEA and CA19-9 was normal, and she denied alcoholism and smoking. And 10 years before, she developed diabetes, and she was using metformin and Victoza. The total bilirubin was normal. Pancreatic cystic lesion. The diagnosis was IPMN or a pancreatopathy sequel. Unfortunately, we have no images. And the second exams was an EUS 1 day after that show a small pancreatic cystic lesion to be a branch duct IPMN measuring 7 millimeters with no main pancreatic duct communication. Was not performed FNA because of the size of the pancreatic cystic lesion. So here we can see the 2 pancreatic cystic lesions and the eusinate process of the pancreas. And here we're going to say about the management of the pancreatic cystic lesion according to Fukuoka from 2017. Let's say if we have an image from CT or MRI that's suspicious of pancreatic cystic lesion and highly suggestive of diagnosis of main duct IPMN, of a mucinous cystoadenoma, a solid pseudopapillary neoplasm, a cystic neuroendocrine tumor. If the answer is yes, we should consider surgery. If the answer is no, we have to look to MRI findings. If the cysts have at least 15 millimeters, have any solid component inside, have main duct dilation over 5 millimeters, and cyst-related symptoms. Pancreatitis or jaundice. If the answer is no, we have to perform MRI every year. And if the answer is yes, we have to perform EUS FNB. In some cases, the MRI findings are not clear. And maybe if we aren't sure about the findings of the MRI, we should perform a US FNB too. So 2 years after, she performed a US FNB that showed in the the body one with the elongated area was regular with poorly defined hypoechoic area. So this we can see the cyst and the hypoechoic area here. So was performed the biopsy that showed the immunohistology with the cystic structure with simple columnar epithelium with linear arrangement with no atypic cells on the fibroblastic wall with the spindle cells. Has no mitotic activity and no necrosis in the sample.
At this moment, Tariq, I would like to know the comments of Dr. Philadelphia Venko. I don't know if Philadelphia Venko is with us, but I would like to hear the comments of Philadelphia Venko.
Yes. Well, it's not very common to find a wall on the cystic lesions through FNB or even FNA. So this case calls attention due to this wall. So if we have the concept of no communication with the main pancreatic duct and a cystic lesion isolated and with a thickness of the wall very high for a FNB biopsy, we can imagine at the first moment that it may be mucinous cystic neoplasia. And we have to check through immunohistochemistry if the stromal component of the wall is an ovarian type of the stroma. So what we found was a very weak reaction to estrogen and progesterone receptors. So I would like to leave this discussion for the next moment, but let's keep it in mind that it's a very weak estrogen and progesterone receptor at immunohistochemistry.
I would like to hear the comments of another pathologist inside with us. Some comments, please.
Yeah, it's a very beautiful lesion. We have a stroma receptor for estrogen and progesterone, and I'm seeing here at the diapositive the gastric type lining epithelium. It's a very beautiful lesion.
Okay. Only to remember, the lesion was punctured with a AUS core biopsy and not a fine needle aspiration. This is a really important detail that we need to show for you.
Yes.
Okay, Tariq.
Yes, it's very important. We always use microhistology, not cytology, for the study of that lesion. All the lesions.
So
you can continue.
Cystic neoplasia with lining epithelium, gastric type, with weakly positive estrogen receptor and progesterone receptors, and Ki-67 less than 1%. So the follow-up was made 2 years after. The MRI showed a numerous cyst up to 15 millimeters with no main duct communication. With in the body, we can see a cyst measuring 13 by 5 millimeters with thin or smooth walls and a nodule of 2 millimeters with no main duct communication and no post-contrast enhancements.
At this moment, I would like to know the comments of Dr. Susan about the MRI. And
well, this is only the post-contrast MRI. And what I think when we are leading to IPMN, any cystic lesion, it's very important to see a T2 weighted image, and preferably the CPMR image, and then to correlate the findings of the septum, if there is any kind of enhancement nodule in the post-contrast image. I think this is a very, very important feature that you have to see. Then I always look for the cystic lesion in the T2. I look for septums and nodules. And then I do a very high, very thin acquisition in the post-contrast to see, because all the septas, all the nodules, they are really, really small. And if I'm looking to be close to a echo endoscopy, I have to perform a very strong exam. At this point, this image, what I can see, it's a cyst with a thick wall. That's my guess here. It's a cyst with a thick wall, and I'll look for more detailed images to have a better diagnosis.
Thank you very much, Susan, for your comments. Tarek?
So continuing, in the same day, we perform an EUS that showed the multiple cysts in the usinate process. Measured 1.3 by 5 millimeters, had no made new biopsy because of the previous biopsy has mucinocystic neoplasia. We can see a contact with a poorly delimited, heterogeneous, and soft isoechoic area to elastography, and no change compared to. So was performed a robotic central pancreatectomy. This is images from the resected pancreas. Here is the cyst. And in the final diagnosis, we can see 13 millimeters. We can see the atrophy of the epithelium, and we can see a thickness of the wall here, measuring by 2 millimeters. Probably this is the nodule that the MRI is shown, but in the histology we can see thick wall. In another slide, we can see
now Tarek, now I would like to know the comments of Philadelphia Venko about the operative piece.
Okay. If you look at those images at the right, we can see a very high thickness of the wall again, and that nodule that Tarek has mentioned through the wall, not the epithelium. Okay. When we find the cystic lesion, this main axis, we can see atrophic epithelium. On the opposite side, we can see very, very high columnar epithelium of gastric type. Again, our attention is to understand the wall. So next, can we see the next slide?
Next slide, Tarek.
Mudei.
Oh. No.
No,
Okay.
agora. No.
On the next slide, when we see the progesterone receptor, again, is very weak. And for estrogen, also very weak. And CD10, that could show us the ovarian stroma, it's also very, very weak demarcation. So what kind of cystic lesion is that? If we follow the World Health Organization, we would have to classify it as mucinous cystic neoplasia, but with stromal ovarian or not? That could be the question. And I would like to hear other panelists for this discussion. Oh,
yes, I think this is an important discussion.
Proliferation index is very weak, very low, less than 1%, and P53 is negative.
And now we would like to hear the another pathologist with us.
With that stroma and that lining epithelium, I think as a cystadenoma.
You think that this lesion is a mucinous cystadenoma?
It can be,
right?
Yeah.
Yeah. And I think this is the last slide. Okay, that this patient. Well, yes. Now I want to hear Dr. Thilo about the case and management of this patient, and if he would have done something like different about this case and the other surgeons with us.
I was a little surprised actually that you already did the robotic central pancreatectomy. I think I would have, in this case, actually waited a little longer, from my impression.
I would too.
Okay.
I would too.
Felipe?
I would wait longer too.
Felipe?
Oi, Celso, desculpa, qual que é a pergunta que cortou aqui para mim?
Oh, I would like to know your opinion about the diagnosis and the management of this asymptomatic pancreatic cystic lesion. If you would have done something different from this patient.
Yes, I think usually is a mucinous cystic lesion. We usually go for surgery. But I think that there is still some controversy on depending on the patient, the risk of the surgery, the patient fit, and the extensive of the surgery and possible complications. In general, the answer would be yes, go for surgery. But in some elderly patients with a lot of comorbidities, depending on the risk of the surgery, if there is no clear evidence of malignant neoplasia, we may observe some selected cases, but usually
yeah, considering that most of this.
Also, how's the size of the lesion?
The lesion size 1.4, yes, 1.3 centimeter.
Okay.
And after surgery, the lesion was shown at 1.9 centimeter.
Weight and surveillance. Yeah, I'm surprised too with the indication of the surgery because there's no evidence of malignancy.
Perfect.
Yeah, I agree.
That's very important. How we have to indicate a surgery if you have a biopsy showing a benign cystic lesion, only because it's a mucinous neoplasia. There's no dysplasia, no proliferative activity, P53 negative. So as us as a pathologist must understand a new classification, a cystic lesion with no ovarian stroma, but with the benign presentation. Why we have to operate just because it's a cystic lesion? That's my concern.
Celso.
Oi.
Can I make a comment?
Yes.
Why do echo endoscopy in these patients? We can follow these patients based on all the guidelines with MRI.
The patient was submitted to the EUS, not for me, but the surgeon demands to do the EUS. And the patient is a doctor, a physician. And the patient was really worried with a result of the MRI. For example, I indicated for this patient only wait and watch, but the patient don't agree with me and think to surgery is better than the wait, because the age, because the clinical situation and the other things. What is the problem with this patient? But in my opinion, I think we have to review all of this management, all of these guidelines for the management of pancreatic cystic lesions. Because, for example, in this case, for example, we note the procedure, a procedure of a robotic pancreatic central pancreatectomy in this patient, that I agree with Dr. Thilo, and the surgery. For me, in my opinion, I think we saw an over-treatment to this patient, and I would like to know the opinion of all panelists about this.
And also, can I make a question?
Sorry?
No, just a question. So just to be sure, this is not an IPMN, right? It's a cystic.
Yeah, not an IPMN. This is
okay.
Mucinocystadenoma. This is quite different.
Yes, exactly. So even though we recognize that there's the role of the surgery, maybe in this case, I think we feel very comfortable with surveillance. Of course, depends on the patient too. And also, just to let you know, we are reviewing our cystic lesion surgeries. And yes, I think indeed we may have to analyze our data comparing you with the previous guidelines. What we have seen is that most of the cases with worrisome factors, when you operate it, most of the situations it doesn't confirm. So maybe I'm just raising a point for discussion here. We can wait and make surveillance for these patients much more than we think.
Yeah. I agree.
But I think all these lesions have to be classified. So I would suggest that yes, you echo endoscopy with biopsy. I think it should be performed for you to have a time zero for the segment of that patient.
Celso, I absolutely agree with the conservative treatment for this patient in special. My question is, as we have a mucinous lesion with a gastric epithelium, and we are assuming it's not an IPMN because we haven't documented communication with the pancreatic ducts. Although we know most of the IPMN will have the gastric epithelium. My question is, how can we be sure this is not an IPMN communicated with a small secondary branch with this gastric epithelium? And once we have done the biopsy and we've seen the gastric epithelium, by our experience on IPMN, we know that the gastric epithelium is less, it's the less possible to have a transformation for a malign disease. So I will be more comfortable after the biopsy not to indicate the surgery for these patients once we have seen it's not an ovarian stromal epithelium. And my impression is maybe this is not a cystic lesion as we normally see on mucinous cystadenoma, and this is quite a long cyst that is the most common for us to see on IPMN. I think maybe this have a small communication with the small branch duct and this a secondary IPMN with the gastric epithelium.
Okay, I agree with your comments, but I think this question will be respond for the pathologist because all of signs or findings don't show main duct communication with this lesion is completely isolated. Even with the operative specimen, there is completely derivated to the main duct communication. This is a really interesting case because this patient, this is another interesting point because this case was in follow-up with MRI by IPMN, and it was not an IPMN, a mucinous cystadenoma. This is quite different, but the result of the final result was intriguing. This is really interesting.
The final result is this patient shouldn't be operated on, probably.
Yes, yes.
Overtreated.
And o fato de você ter múltiplas lesões também não fala a favor de IPM. Oh, sorry. As you have multiple lesions, is it more probably to be a IPMN than a mucinous cystic lesion?
Yes, this is a really interesting point. The problem is all exams, MRI and EUS, identify a lot of lesions, two in mucinate process, one in the neck of the pancreas, one in the body, but all of these lesions, even with the MRI and even with EUS, main duct communication is no.
Must be very thin.
Yes.
Celso.
Can I?
And it may communicate with the secondary branch. Then it would be much harder to see.
Yeah.
So,
can I comment?
Yes, Susan.
The problem is it will be a really difficult answer because as we've seen and as we've shown, like 10% of all patients that goes to an MRI presents multiple cysts and they don't go to surgery. Maybe we will find, if we could go to surgery or pathology, maybe we will find more of those lesions, mucinous lesions, not apparently linked to the duct or IPMNs, but we'll know because we are not examining all these patients. I think this is a bias, and it will be.
Perfect. So that comment suggests us to improve our classification for those lesions, cystic lesions. Many small cystics are only retention cysts, ductal ectasias, and sometimes pancreatic interductal neoplasia, not mucinous. I was not the examiner of that specimen. I would like many slices to prove that. But the pathologist in the other hospital, they classified that lesion, those small cysts, as panin. Okay.
Okay.
Celso.
No.
comment.
The last comment, please, because we move to the another case. Yes.
Okay. In one lesion, in 1.7 centimeters, the differential diagnosis between IPMN and cystic lesions don't change the approach. Okay, it's very nice to know to knowledge the pathology, but doesn't change the approach. Okay.
Okay. We move on to the another case, Tariq.
Okay. Well, the second case, it's a male, 76 years old. He's also a physician. He was presenting jaundice of 3 days of evolution with fecal acholia and coluria. He has systemic arterial hypertension. He was an ex-smoker and has obesity grade 1. He was submitted to retosigmoidectomy due to complicated diverticulitis 10 years ago. And in 4 years of follow-up was detected a IPMN by MRI. So in 2019, cyst measuring 2.3 centimeters was partially esophagic with main duct contact, was suggested to be a IPMN with no worrisome features.
Susan, I would like to hear the comments about these images, Susan.
I think I will go to with worrisome features because there is there is a nodule, 2 nodules inside the lesion. That's my guess here. Yes, I think that there is enhancement of 2 nodules at least.
Yes. Next.
Also, again, here we are talking about the management of the pancreatic cystic lesion. So how the MRI findings have more than 1.5 centimeters, we should perform a USFNA or a USFNB. So
some comments about this
October that show the
this
branch.
case. Let's continue.
So was performed a USFNA in October 2019. The US showed a branch duct IPMN in the pancreatic head with no worrisome features, and the FNA was inconclusive. But 5 months later, the patient got jaundice with elevated lipase, and bilirubin, the total bilirubin was 5. Direct bilirubin 4.38. The CA19-9 was normal 10.9. So 1 year later, he made another MRI that showed a dilation of the common bile duct with the degrees of the distal caliber of the common bile duct and the main duct that had. I also can see a small lobulated cyst measuring 2.3 centimeters with partially esophagic with main duct contact, suggesting again IPMN with no worrisome features.
Susan, I would like to hear your comments about this.
This is the cystic lesion. I think there is a relative thick wall, but for nodules or enhancing septas, we have to go to contrast enhancement.
Okay, let's go.
So 1 day later was performed a USFNB. Here we can see the cyst, the lesion measuring 2.3 centimeters. Here is the video that we are getting the needle to do the biopsy of the cyst. And in this video, we are introducing the needle. It's going to appear here. The needle was located inside the cyst. Sorry, here. The needle was located inside the cyst. The size of the cyst will decrease a little in the end of the video. And then the microhistology results show a well-differentiated adenocarcinoma with histological low-grade primary epithelial neoplasia with tubular arrangement, atypical mitotic activity was present, accentuated desmopia with the possibility of association with
Philadelphia. Some comments about this result.
Oh, generally, we can understand it like ductal adenocarcinoma, but at the right, we can see mucinous production more than common for a microtubular tube. So, with the story of to be a cystic lesion, I think this is an invasion area of possibility of IPMN on the neighbor. There's it's a low-grade adenocarcinoma, not high-grade. So that's how we can manage the idea of histogenesis of that lesion.
Edson, some comments?
Very interesting, a very small cystic lesion. The patient had the luck of being jaundiced. So it led you to do the diagnosis of adenocarcinoma.
Does anyone have any comments?
Yes, I'd like to also.
Yes,
please.
Alexandre.
No. Afterwards. Please, Professor.
No, just okay. Susan. Have you seen the solid component in the cystic in the MRI?
In the first MRI, the solid component was evident in the first one 5 months earlier. That's the question, and that is why. See, in this cyst, and it is not a very nice cyst, because to be a cyst, it should be completely black. And it's evident that you have nodules and Hansen nodules inside this lesion. My guess is this lesion went to an FNA, it was punctured, and it changed the feature. It was like more a nodular lesion, and after the FNA, it became different, and there was again a lot of mucin inside, or liquid cystic lesion inside this lesion, and the second FNB showed the solid component. That's my guess.
Yes.
Because if Susan saw the lesion in the first MIA 4 months ago, I would like to go to the surgery 4 months ago. Without
yes, but the problem, yes, Paulo, I agree with you, but the problem is the MRI that showed it for us was an MRI with a follow-up of IPMN without any signs of malignancy. That's the problem. I don't have all the time, Susan, to see all the exams, and I don't have all the time Philadelphia Venco to see the FNB or FNA. this is an operator dependent. This is a great problem for us. And for you too.
For everybody.
Nice case.
For everybody, yes.
Nice case, nice case. I would like to point out two comments on this situation. First of all, is the possibility of a false negative FNA biopsy. And in most instances, this biopsy with the first one was performed in August 19. This can lead the clinicians who follow this patient with to see these lesions as very benign. Do not perform the correct follow-up for these patients, and later on, this patient will present with a high aggressive advanced lesion. So a negative FNA biopsy doesn't mean this patient doesn't need to be followed very closely. And this is, for me, very important message from this case. The second one, there are a lot of distinct guidelines to manage IPMN. And in most of them, jaundice is considered to be a worrisome factor. For me, it's a panic factor. I haven't seen an IPMN with jaundice that wasn't associated with a malignant disease. So for me, it's a very important sign, the presence of jaundice. It's not a worrisome factor, but a panic factor, in my opinion. So whenever we see a patient jaundice, we have to evaluate it. Maybe it's not associated with the IPMN itself. I myself had a case of a patient. He's had a secondary duct IPMN on follow-up for years. I've seen him, and 2 months later, he came back jaundice. And I said, oh, God.
Okay.
And just to comment, this case, there was an adenocarcinoma of the ampulla, not for the cyst itself.
Good comment.
If you have jaundice, you don't necessitate the biopsy. You should go to surgery.
I absolutely agree. For me, it's a panic sign. Surgery.
Okay. Let's go, Tariq.
So after the result of the FNB, was performed a robotic pancreatoduodectomy that showed the cyst, but unfortunately we doesn't have the result of the immunohistochemic.
Phila, Phila, I would like to hear about this specimen.
Well, I think there's a solid mass on the neighbor of the cystic lesion. That's a multiple cystic lesion with a invasive area by that side, I think.
Yes.
What kind of epithelium, Philadelphia?
Oh, after Paulo, we will discuss this. Okay.
So
let's go.
In the surgery,
this is the evaluation of intraoperative.
Yes, the patient evaluated with shock, with necessitating high doses of noradrenaline and vasopressin, with improvement after expansion with volume more than 10 liters. Was start ceftriaxone and metronidazole. And the next day, he received 4 blood concentrations due to 15 later, he was discharged.
And now I would like to hear all surgeons about this evaluation of this patient, because for me, for us to follow this patient was a really disaster during the surgery. And I would like to hear the opinion of the surgeons. Paulo.
It's not common to have an intraoperative shock, although there was a huge vascular lesion that's quite clear on intraops. So a shock that occurs intraoperatively is very rare, and it can be very damaged for the follow-up, for the postoperative, because once you have it, a distributive shock, the perfusion of the small bowel will not be okay, the pancreatic stump will not be well perfused, the incidence of pancreatic fistula will be very higher. So whatever caused this intraoperative shock, maybe a sepsis, an occult sepsis on pre-op, maybe the occlusion of the main pancreatic duct leading to a pancreatitis. It's difficult to say, but it's not common to have this presentation. And this can lead to a very difficult postoperative course, in my opinion.
No more comments.
Okay, let's go.
This is the end of. Thank you.
The final diagnosis. We need to show the final diagnosis.
Unfortunately, doctor,
okay. You have some problems with the internet, but the final diagnosis was a cholangiocarcinoma. And cholangiocarcinoma from the distal common bile duct, and PT1NO, the final result. Sorry for the last slide.
And it's interesting because I had this case myself that was an ampuloma, a tumor from the papilla on the biliary verge of the papilla, and was not associated with the IPMN. The IPMN was also resected. There was no signs of, there was a low-grade dysplasia and no signs of invasive disease on the IPMN.
Okay. Some comments? I think really important with a final comment is that small cystic lesions identified by MRI or CT can surprise us. This is really interesting. In this case, for example, the epithelium, the question was, the epithelium of this lesion was a pancreatobiliary epithelium of this lesion of the cystic lesion finding for the US or MRI. Some questions, Edson, Felipe?
No.
Okay, então we move on to the, thank you, Tarek, for the presentation. Thank you, Paulo. Thank you, Alexandre, you all for the comments.
Very nice presentation.
Thank you, Felipe. And we'll move on to the Hospital do Servidor Público do Estado with Francisco Fará, that show us acute pancreatitis clinical case discussion. Fará?
Estou aqui.
Okay.
Oh.
The presentation is you.
Celso?
Oi.
Dr. Thilo is not here anymore?
I don't know. I can't see you.
I'm still here, but I have to leave now. I'm sorry.
Okay. Dr. Thilo, do you have some comments about the cases? Sorry.
But if you want to hear some minor comments on the last case, I think there's two things to mention. The one thing is that size in IPMN is not telling us anything. And the second thing is what we have just recently learned is that the IPMNs in the uncinate process have some higher potential of malignancy than elsewhere in the pancreas. We don't know why. Maybe this is the embryological thing, but somehow the uncinate IPMNs are much more aggressive, I think, than the rest of the pancreas.
Oi.
Okay. Good. Thank you for your comments, Professor Thilo.
Sorry, I have to leave, so thank you very much to everybody.
Thilo, I appreciate
Não, ela tá azul.
O Kiko podia desativar os textos.
Kiko, desativa o seu microfone, por favor.
Já desativou.
Dr. Thilo, the final comments, I think.
I just wanted to say thank you for the invitation, because I unfortunately have some other appointment now and have to leave you. And I think you can still discuss on the acute pancreatitis now. I'm looking forward to see you all in person again sometime, hopefully. Thanks a lot.
Thank you very much.
In Brazil.
Thank you very much.
You know.
Thank you. Bye-bye.
Bye.
Thank you very much, Thilo.
Thank you very much, Professor Thilo.
Thank you, Thilo.
Considerando o último caso, enquanto o Kiko apresenta lá, uma outra coisa que me ocorreu que pode causar esse choque intraoperatório durante a cirurgia, Celso, é trabalhar com o pneu peritônio muito aumentado. Isso facilita tecnicamente, às vezes, mas aumento da pressão intraabdominal pode levar à alteração perfusional e esse choque distributivo. É uma outra possibilidade para esse choque intraoperatório, que é muito raro, realmente.
E esse caso, Alexandre, ele tinha muitas comorbidades, né? A gente não elencou todas as comorbidades, mas ele tinha muitas comorbidades. Era um procedimento operatório de risco. Mas o que chama bastante atenção para a gente é que a lesão, que a primeira ressonância, eu fiquei desconfiado, como a Susan, de que havia alguma coisa ali. Quando eu fiz a primeira ecoendoscopia, não sei se vocês se ativeram, eu encontrei uma área nodular ali. Tanto que eu biopsiei aquela área nodular. Pela ecoendoscopia, já achava que tinha alguma coisa, né? Agora, isso é realmente... O que chama atenção é que tinha uma ressonância magnética que não tinha praticamente nada, né? E depois a ecoendoscopia mostrou realmente uma área nodular, né? Grande, ao lado de um cisto. E a gente fez a biópsia, e a biópsia veio um adenocarcinoma. Então, isso que chamou bastante atenção.
Eu acho muito interessante mostrar esse caso para mostrar a possibilidade de falso negativo em biópsia, sabe, Celso? Porque isso aí, muita gente seguia pelo resultado da biópsia. Pegou o resultado da biópsia, pus no bolso, eu estou tranquilo. E não é assim. A gente sabe que o resultado da biópsia não é 100%. A gente não tem uma sensibilidade tão alta.
E uma coisa que eu sempre digo é o seguinte, é isso que eu quero deixar claro. A biópsia tem que ser feita não citologia, tem que ser feita microhistologia. E hoje, com a core biopsy, ela vai ajudar muito o cirurgião a fazer esse tipo de procedimento. Então, isso é fundamental. Você está autorizado a fazer esse tipo de procedimento. Nós estamos aqui discutindo e vamos continuar discutindo até esperar o Fará passar.
E a core biopsy ajuda o patologista de sobremaneira também. É muito melhor e dá muito mais segurança na nossa avaliação. Dá muito mais segurança, inclusive na avaliação imunohistoquímica, se for necessário fazer um painel um pouco mais amplo. Nossa, é bem diferente.
Olha, Zé, nós temos o caso, por exemplo, de massas pancreáticas, de leucemia mieloide, por exemplo, de sarcoma de pâncreas detectados com imunohistoquímica e tudo por ecoendoscopia com biópsia. Nós vamos realmente até mostrar aí alguns casos. Eu acho que realmente a core biopsy é um procedimento que veio para ficar.
Eu acho assim, eu acho que a responsabilidade do triador é fundamental, e é por isso que eu acho que é muito importante a gente deixar isso claro. Parece muito fácil. Faz uma ressonância com colangio-ressonância, né? Faz ressonância com colangio-ressonância. Mas o que a gente percebe é que em lesões pequenas, ou você faz um exame muito dedicado, ou você não vai ver.
Exato.
E, contrapartida, quando você vê, e se você viu, você não pode sossegar, é que nem mama. Se existe uma desconexão entre o achado de imagem e o resultado da patologia, e eu faço mama, e isso é muito comum, a gente não para. Ou a gente manda para uma incisão cirúrgica, eu estou dizendo a mama, e a mama é mais fácil, ou você tem que repetir a biópsia. Então, nesse caso, com aqueles nódulos vascularizados, talvez tivesse que ter repetido mesmo a biópsia, mas isso se você tivesse a informação que, veja, tem características muito suspeitas de, né? Então, não eram só worrisome features, era realmente estigma já de neoplasia, porque era um nódulo, não era apenas, e olha, você só mostrou uma imagem, e não era um septo irregular mais espesso, era um nódulo com realce. Mas, para isso, você deveria ter a informação do triador.
Exato.
Não pode não ter a informação do triador. Então, você foi com uma informação de um triador que não era nada, você teve uma biópsia que não mostrou, então você ficou tranquilo, até evoluir com uma icterícia.
Só uma coisa, Susan, a biópsia que foi feita por FNA não foi feita no nosso serviço, foi feita em outro serviço. Essa paciente chegou para a gente só para fazer a segunda biópsia, tá? Isso é que é importante. Tudo aquilo que foi mostrado, aquela ressonância, aquela biópsia, não foi feita no serviço, foi feita em outro serviço. Quando chegou para a gente, eu já indiquei de cara a FNB, porque eu já sabia que já tinha uma FNA que era inconclusiva. E eu tinha visto, e eu vi a ressonância, a primeira ressonância, que precedeu a ecoendoscopia com biópsia anterior. Mas o que chama atenção, e o que eu queria salientar, é que cada vez mais a gente tem feito as biópsias com agulha fina em lesões pequenas das císticas pancreáticas, que já estão com follow-up de longo tempo, e a gente tem encontrado câncer, viu? Nós não temos esse detalhe ainda de qual a nossa porcentagem, mas a gente tem encontrado câncer. Eu estou passando alguns casos aqui, eu tinha até mais um outro caso para mostrar para vocês, que é a mesma coisa.
Ô Celso, no trabalho que a minha aluna de doutorado continuou, que foi o achado incidental, a prevalência de cistos pancreáticos, né, na população, que a gente publicou lá no Plus One, e que a gente continuou, quando ela mostrou a defesa dela, ela mostrou que aqueles cistos que tinham algum estigma e aqueles que você, inclusive, fez a FNA, ainda você não fazia FNB, mas foi a FNA, tinham já casos de low grade, tinham casos de atipia e de adenocarcinoma de baixo grau. Então, assim, é fato.
Ó, e o Eduardo Ramos está lembrando aqui que aproximadamente 5%, eu diria até que uma porcentagem um pouco maior, hein? Não é só 5% das cirurgias de Whipple não mostram neoplasia em grandes serviços, né? O falso negativo é pior em alguns casos, a gente tem que lembrar disso também. Então, por isso que realmente eu sempre falo, isso é uma discussão minha, eu nem sei porque que o Paulo Amaral não apareceu até o momento, mas é uma discussão muito forte minha entre o Paulo Amaral e eu, né? Porque eu acho que você viu que a pergunta que ele fez foi por que foi feita com endoscopia desse paciente.
Só um minutinho, eu estou dizendo o seguinte, eu acho que isso tudo pode ser resolvido com o tumor board. O que acontece comigo? Eu recebo paciente que vem de um serviço que eu não conheço o radiologista. Eu vou encaminhar para o meu radiologista falar. Então, se eu tiver Susan, eu vou encaminhar para a Susan, porque, repare bem, eu acho que a ecoendoscopia, eu não sou contra a ecoendoscopia, Celso. A ecoendoscopia está indicada quando você tem sinais preocupantes, todas as vezes. Esse paciente não tinha nenhum sinal preocupante. Como o Alexandre falou ali, ele tirou um sinal, como é, Alexandre, de alarmante. De pânico.
Pânico, eu adorei! Pânico!
Não é sinal de alarme, é de pânico.
Eu amei! Eu vou colocar nos laudos.
Mas só lembrando, agora eu quero só fazer jus, eu não quis responder isso na hora, mas só lembrando que quando a gente compara, existem trabalhos comparativos entre a ressonância de primeiro ponto, né? Ou seja, ela fez a ressonância, fez o IPM, e depois esse paciente vai para a ecoendoscopia, existe uma discrepância de resultados de aproximadamente 12% de nódulos e septações, ou até mesmo, como nesse caso, que tinha uma massa ao redor do cisto, uma região hipoecóica ao redor do cisto.
Então, é óbvio que tanto para a ecoendoscopia quanto para a ressonância, operador dependente, né? Mas em mãos hábeis, né? Você vai fazer o diagnóstico, vai conseguir fazer a biópsia e vai dar o diagnóstico, né? E sempre lembrando que também a chance de você ter complicações, ela é muito pequena. Ela é muito pequena de você ter, por exemplo, perfuração, ou sangramento, ou pancreatite aguda. É realmente muito pequeno. Eu acho que o Fará já tá pronto, Ana, por favor, você sabe? Se você quiser passar o vídeo, pode passar, é o vídeo promocional do pessoal que está nos ajudando, enquanto o Fará acerta a apresentação dele. A Olga Dias, é claro, a Olga Dias, não o Fará.
Eu vi Olga.
Ela vai passar agora, pode passar,
Não está passando,
tranquilo.
gente. Sinto muito, não. Nós estamos aqui com a assessoria. Opa, peraí.
Agora vai passar um vídeo, não, ela vai passar um vídeo da Procor, aqui vocês estão vendo hoje como é que é as agulhas Cor, acho que é um ponto interessante.
Oi. Agora o Celso está me chamando aqui na frente, aí eu vou ficar rolado de vez.
Sou eu que estou te chamando?
Seu áudio tá ligado, hein, Kiko? Cuidado.
Não tem som?
Essa é uma mamotomia no pâncreas. Isso é uma
Não, eu acho que é muito interessante vocês terem essa noção para vocês verem como é que é a obtenção tecidual. Olha a diferença do que era antes.
Exatamente, isso é uma mamotomia. E deve ter o vácuo aí, não tem?
Sim, tem o vácuo, claro. Você liga no vácuo, exatamente.
Só eu que eu faço na mama, você faz no pâncreas.
Exatamente.
Muito bom.
É bem bacana. É outra qualidade de espécime. Outra.
Sem dúvida. Não tem artefato de compressão, não tem um monte de coisa. Né? Fica muito boa de ver.
Gostei do seu comentário, que você falou que realmente o core ajuda bastante a gente a fazer o diagnóstico. E é exatamente isso que a gente tem observado mesmo. Você já tem recebido, Gabriel, material de core para pâncreas ou não ainda?
Eu recebo, às vezes, antes eu recebia mais, antes de eu vir aqui para ser Camargo, lá no Rio Grande do Sul, tinha um pessoal que fazia bastante.
Celso, deixa eu fazer um comentário a respeito do caso. Felipe está aí ainda, enquanto a gente não entra, que é o seguinte, ó, quando aquele primeiro caso que Felipe mostrou, é interessante como a gente está vendo esses 2 meses, eu tive 3 pacientes, esse agora de Felipe, o terceiro caso de neuroendócrino grau 3 com capitano no PET Gallium, o que não seria uma coisa esperada, né? O que a gente sabe que o PET Gallium normalmente é um tumor barra bem diferenciado. Esse é o terceiro caso que eu vejo em 2 meses. Essa era a primeira questão. E a segunda, eu já debati isso com o Herbert também, é o seguinte: está certo esperar no tumor menor, entre 1 e 2 centímetros, você pode esperar sim, pelo guideline europeu e pelo guideline nosso brasileiro, mas também está certo operar esses doentes pelo guideline americano e pelo guideline asiático. Então, eu acho que se o paciente é jovem e ele tem um tumor entre 1 e 2 centímetros, principalmente na cauda, eu opero todos, principalmente por essa divergência que a gente sabe, os patologistas sabem, que ocorre no KM67, que é heterogêneo. Então, a gente já teve biópsia de paciente jovem com KM67 de 2, a gente não levou em consideração, operou e era de 10. Então, é só isso que eu queria dizer. O PET Gallium, capitano tumores G3, né? E a possibilidade, sim, de operar doentes com tumores entre 1 e 2 centímetros, baseado no guideline americano e do asiático.
Não, concordo plenamente com você, Paulo. Só que quando você tem uma lesão pequena e que você tem um KI67 baixo mesmo, não tem por que você não wait and watch. Essa é a minha impressão. Principalmente se a lesão estiver na cabeça do pâncreas. Principalmente se a lesão estiver na cabeça do pâncreas. Não, se está na cauda, se está na cauda, aí não tem problema, entendeu? Eu, por exemplo, eu tenho no meu consultório, eu tenho acompanhado, não são poucos os pacientes que eu tenho acompanhado única e exclusivamente a ressonância. Por exemplo, a própria Susan faz ressonância. Eu controlo esses pacientes com ressonância magnética e os resultados são muito, muito bons.
Com um comentário só, respondendo ao Paulo. Eu concordo, viu, Paulo? Eu acho que não é 100% também não, concordo plenamente. Primeiro, esses tumores maiores, eles podem ser heterogêneos mesmo, né? Por mais que seja grau 3, ele pode ter um componente mais bem diferenciado. E existe uma porcentagem, acho que uns 60%, 50%, que captam nos dois mesmo, né? Tanto no PET quanto no galho. Em relação aos tumores menores, eu concordo. Eu acho que não é só tamanho, não, de jeito nenhum, não pode ser. Como você falou, às vezes um paciente, a gente tem que levar em consideração a informação que a gente passa para um paciente, ainda mais um paciente que entende tudo muito bem, bem diferenciado. É uma cirurgia de baixo risco na cauda, o paciente jovem que vai ter 60 anos de vida, 70 anos, é diferente de um tumor na cabeça, um senhor de 80, 70, né? Então, até porque os estudos, por melhores que sejam, o acompanhamento, o follow-up médio deles é 3 anos, 3 anos e meio, de 3 a 4 anos. Para neuroendócrino de baixo grau, isso é pouquíssimo.
Agora, Felipe, eu queria só fazer um comentário que a radiofrequência por ecoendoscopia nessas lesões pequenas, até na cabeça do pâncreas, tem se tornado na Europa uma atração cada vez maior. Tá? Então, essa boquinha de ficar fazendo pancreatectomia caudal tranquilamente, isso aí vai começar a mudar.
O Silvio e o Alex colocaram um slide na apresentação, eu quase falei para ele tirar isso, Celso.
Obrigado, eu só tenho que te agradecer, bicho. Não, o Silvio foi fantástico.
Não, eu estou brincando, eu acho que talvez seja uma opção mesmo que vai vir. A gente não tem experiência nenhuma, mas de repente é uma novidade.
Mas nós estamos para começar com essa experiência agora, nós estamos já está sendo, parece que a Anvisa vai aprovar e a gente vai realmente iniciar com esse tipo de procedimento. Bom, eu queria saber exatamente se o...
Deixa eu aproveitar vocês, porque eu tive um caso assim complexíssimo e desafiador e eu queria ver se alguém já tinha tido contato com isso. Me veio uma paciente com uma hiperinsulinemia, né, suspeitíssimo de... A endócrino falou, você tem que achar um TNE, tem que achar uma insulinoma. Tem que achar, porque ela tem. Muito bem. Fez exame, todos os PETs possíveis e imagináveis, todos negativos. Aí veio fazer uma tomografia comigo negativa. Aí fez uma ressonância comigo negativa. Aí eu falei assim, não. Primeira coisa é que algumas vezes existem alguns insulinomas que a gente não consegue ver na ressonância, é melhor até a gente fazer e ver na tomografia. E aí eu falei assim, eu vou fazer uma perfusão aqui pancreática na tomo, vou fazer 300 fases, já que a mulher me falou, eu preciso achar isso. Muito bem, não achei, mas esse pâncreas tinha um aspecto um pouco diferente, né? E aí eu fui ver, ela tinha um bypass gástrico. E aí ela tinha um aspecto de nesidioblastose mesmo, pancreática. E quando eu fui ver, ela pode ter uma nesidioblastose pós-bypass gástrico. E aí eu queria entender se vocês já viram isso, já vivenciaram isso, porque é uma coisa assim muito louca.
Souza, eu tenho um caso muito interessante, que é uma nesidioblastose pós-gastrectomia total. O paciente tinha feito uma gastrectomia total e a reconstrução tinha sido com interposição de alça entre o esôfago e o duodeno, uma técnica que até é pouco usada. E esse doente desenvolveu hipoglicemias graves e tudo, mas na análise dele de PET com somatostatina, na análise de somatostatina, ele captava de forma difusa na cabeça do pâncreas. E não captava em corpo e cauda, era só na cabeça. Então, nós fizemos nesse paciente uma ressecção exclusiva de cabeça de pâncreas, preservando o duodeno, e essa paciente agora tem 4 anos de acompanhamento sem novos casos de hipoglicemia. E era uma coisa mais rara ainda, que é uma anesidoblastose localizada só na cabeça de pâncreas.
Gente, eu fiquei muito louco.
Em Ribeirão Preto, nós tivemos um caso exatamente assim, que é exatamente como a Susan falou, muito difícil o diagnóstico, mas a biópsia foi suspeita para anesidoblastose. Foi feita uma biópsia, porque eles pediram, porque eles já, na verdade, eles já suspeitavam que pudesse ser uma anesidoblastose. E pediram para fazer uma biópsia do parênquima. E nós fizemos uma biópsia do parênquima e ela foi sugestiva mesmo de anesidoblastose. Tem que lembrar que esses casos são muito difíceis mesmo de fazer o diagnóstico, né? Realmente bem difícil mesmo. Eu queria perguntar para o Fará se ele vai conseguir entrar ou se a gente pode realmente... eu queria conversar.
Doutor Celso.
Oi.
Ele estava reiniciando o computador, mas ele não conseguiu achar o link para poder entrar novamente na sessão. Ele pediu para deixar para uma próxima oportunidade, mas eu acho que ele deve ligar para o senhor.
Não, tranquilo. Bom, então, gente, é o seguinte, eu queria assim, agradecer mais uma vez a oportunidade que vocês me deram de, entre aspas, ajudar na idealização dessa... Porque eu sou, como vocês sabem, eu sou um estranho no ninho, né? Apesar de ter feito cirurgia, eu sou um completo estranho no ninho, mas eu tenho muito apreço por todos os cirurgiões, porque eu acho que realmente é muito enriquecedor, eu aprendo muito com vocês, não só com vocês, mas também com a Susan e com os patologistas, né? E eu queria abrir a finalização desse curso, desse evento, que foi um sucesso. Nós tivemos mais de 115 pessoas entre YouTube e aqui, junto com a gente, né, no Webex. Eu acho que foi uma discussão de alto nível e realmente muito obrigado por essa oportunidade. E eu gostaria de passar a palavra para o doutor Edson Lobo, para o doutor José...
Eduardo.
Esqueci seu nome, Zé. Pelo amor de Deus, hein? E também Zé Eduardo e para o doutor Ademar, para o doutor Ademar. Desculpe, Zé.
Você vai chamar só de Zé, isso vai ser o Eduardo, né?
Antes deles, vocês estão me ouvindo?
Zé Eduardo Monteiro da Cunha, meu grande amigo Zé. Fala aí.
Alô, estão me ouvindo?
Sim.
Claro,
sim.
doutor Ademar.
Então tá bom, gente. Eu queria deixar o meu agradecimento a todos, né, pela participação, um grande empenho que o Celso teve, o Zé Celso, aí na organização do evento, agradecer o apoio da Eta Mucino para que a gente pudesse estar aqui nessa manhã de sábado, e cumprimentar a todos pela excelência da reunião. E eu gostaria, antes, de ouvir o Edson aí nas suas palavras finais e pedir para que o Dr. José Eduardo desse os comentários finais. Muito obrigado a todos.
Obrigado, Ademar. Olha, realmente fiquei muito feliz com o entusiasmo de todos os participantes. Foi um sucesso total, apesar de algumas dificuldades técnicas minhas aqui com o meu aparelho, com o Kiko, mas a soma final foi muito boa. Só tenho que agradecer e tentarmos repetir esse tipo de atividade. Muito obrigado a todos e principalmente aos organizadores. Obrigado.
Ademar, obrigado por me dar a oportunidade de fazer os comentários finais, mas isso aí seria totalmente dispensável em função das suas palavras anteriores. Mas eu acho que realmente essa reunião coroou assim, com grandes méritos o nosso grupo de estudo de doenças do pâncreas. Eu fico muito feliz que naquele nosso café, eu, você e agora o coisa que é o meu nome, agora esqueci o nome dele.
Tarcísio.
José Celso.
Tarcísio.
O Tarcísio Trevino, isso. Então, foi muito feliz a nossa iniciativa de criar esse grupo, que hoje em dia já se mostrou, então, com toda a sua pujança, com toda a sua... com tudo que pode colaborar, e essa reunião de hoje realmente foi extraordinária, no sentido de reunir, foi uma reunião internacional, afinal de contas, tivemos aí o professor Thilo aí contribuindo significativamente para a reunião, e Celso, parabéns pela iniciativa da organização disso, e vamos esperar que isso continue agora com maior frequência daqui para frente. Muito obrigado a todos e muito obrigado pelo convite para participar da reunião.
Obrigado,
fazer mais Olha, só um comentário. Essa reunião está gravada, tá? E eu vou disponibilizar o link no YouTube, no grupo do GDP e para todos os convidados, tá bom? Até logo para vocês. Muito obrigado pela oportunidade. Tchau, professor José Eduardo Monteiro da Cunha.
Agora
e todos os demais.
Bom.
Agora não esqueça mais, hein, Zé?
Oi.
Tchau.
Tchau. Memórica aí para quem não tem,
Parabéns.
Não tem acesso à
Sim, eu coloco
comunicação.
quando eu tiver o link.
Só uma coisa.